All right. Good morning, everyone. Let's get started. Welcome to the NIDDK workshop on AI in precision medicine of diabetes and other chronic diseases. I'm Zhiyong Wang, a program director at the National Institute of Diabetes, Digestive and Kidney Diseases, i.e. NIDDK. See how. So planning this, it's not for planning this committee has been a team effort. I would like to acknowledge my NIDDK colleagues serving on the planning committee. Also want to extend a special thanks to our external workshop co-chairs. Their contributions have been invaluable, and they are Dr. Marcela Brisova from Vanderbilt University, Dr. Jeff Graff from UC San Diego, and Dr. Wei Wang from UCLA. Thank you very much. And now we are honored to have Dr. Rob Starr, Director, Division of Kidney, Urologic, and Hematologic Diseases, the NIDDK, who will deliver opening remarks. Thank you, Rob.
Thank you. So I want to bring my warmest welcome from Dr. Griff Rogers, who's the director of NIDDK, and also Dr. Germino, who's here, the deputy director, and Will Cefalu, the director of the Division of Diabetes, and welcome you to this very timely and important two-day meeting on precision medicine and artificial intelligence. As you all know, over the last couple of decades, we've developed these, especially in the last couple of years, these very large data sets that have beautiful signals for biologic processes. And our job here is to try and figure out how to turn these signals into something that can actually help patients with diabetes and other chronic conditions. Artificial intelligence and machine learning give us the tools to do this, but as we'll see, there are some problems. So the objectives of today's meeting are to discuss the unique and transformative opportunities in precision medicine that are offered by recent advances in these large data sets and using AI and other data science areas, to then discuss the status of artificial intelligence in analyzing the data to help us take what we've always thought was a single condition diabetes and turn it into its subsets or subphenotypes or endophenotypes, as well as other chronic conditions such as liver disease, kidney disease, urologic diseases that run with diabetes, that are complications of diabetes, and then discuss sort of what's missing, what are the needs and gaps in this area. And especially, you know, there's going to be a lot of presentations from the podium here, but it's only really a small part of what's going to happen in this meeting. There are a lot of breakout groups where you'll be discussing some of the questions that are put forward by the planning committee. But the real conversations I've always found take place in the corridor. And the really nice thing about this building is the corridor is really small and it forces you all to interact with each other. And it looks like MIT building 20, looks like Google headquarters. That's where the real meat of this meeting is going to take place. So please, please do interact with each other. I want to congratulate the people who have been selected to give, the trainees who have been selected to give the flash talk presentations that we presented later this morning. We're looking forward to hearing about your exciting research and really encourage everyone to attend the poster sessions in the afternoon to support our trainees. Now, one of the questions that I've had in this area is how do we turn the hype of AI into hope for our patients? And so I want to bring up two things. More will be brought up during the meeting, but I wanted to put on the table two things. And one is that just like in clinical trials, there are a number of things that we have to consider as we think about using AI to make our algorithmic development and deployment safe, ethical, rigorous, and effective. And to this end, NCATS, the National Center for Advancing Therapeutic Sciences, has developed something called GAP that's similar to GMP and GLP for those in the clinical area. They're good algorithmic practices that go through what's needed in order to use AI effectively. And the first thing on my list and their list is to continuously and extensively validate AI models rigorously. It's important even before you put pen to paper or finger to keyboard in the area of AI to actually think about these as you design your studies, because what we've seen is that many things work well in one setting but can't transfer to a second setting. The other really interesting part is that as they begin to deploy into clinical care, they change clinical care, and then for some reason the AI model falls apart. So it's really important to think about these endgame issues very, very early on in the pipeline. And this requires a multidisciplinary team with the kinds of people shown here. Again, back to the thin hallway, narrow hallway, that's where we really do want you to interact. Now, I don't like bringing up a problem without a potential solution. And one thing we're beginning to stand up, and I want to use the word beginning very cautiously, is a renal tenant that has a lot of diabetes in it. So during COVID, NCATS developed an N3C project that brought together about 75 institutions, created a huge enclave of EHR data open to everyone that was used to speed medical research, improve care, and inform policy during COVID. They now have changed this from a COVID focus to a clinical focus and developed a cancer tenant, and we're beginning to develop a renal tenant right now that will have about 20% or so of the data initially, but this is a large, will be eventually open access source that has EHR data and importantly linked to CMS billing data and a whole variety of other things with all the translators that translate the various forms of EHR into a single OMOP common data model. So this is available for you to think about either developing AI models or as a secondary validation source that's completely independent of whatever you have. So I just bring these two things that I've been working on to the meeting because I think they might be interest to the group. So again, welcome. We've already welcomed the external co-chairs. A meeting like this really does take a lot to pull together, many meetings, times to figure out what the breakout sessions should be, invite the speakers, et cetera. So I just want to thank all the organizers, want to thank the contractor SCG that's done the yeoman work to bring us all here, and especially to thank all of you for your continued interest and interactions during the next 2 days. And with that, I turn it over to co-chairs. Thank you very much.
Okay, so good morning, everyone. On behalf of the organizing committee, we welcome the discussions that we're going to be having over these 2 days. Just a quick reminder, we do have a workshop survey that is open until the end of tomorrow. So for those who haven't given their feedback online, we'd really appreciate the additional feedback that people could provide as part of the workshop activities. We did have a pre-workshop webinar. These recordings are available. Again, this is in the lead up to the workshop, so that information is out there. I'll skip over the awardees again. We have travel awardees with poster that are available, and then also the flash talk presenters, which were mentioned earlier. Now the sessions, we have 2 keynotes, one every day. So we'll be kicking off with the keynotes, but the main sort of work I think is in the sessions themselves. And we talked about that we want to have some robust discussions, and so each session will have a number of speakers, and then there's a 30-minute discussion section at the end of each of these sessions. So we hopefully will be able to engage some good discussions there. The first session we'll deal with recent advances in AI and its applications to biomedicine. Session 2 will be focused on AI-based precision medicine in diabetes and other chronic conditions. And then session 3 we'll discuss, the NIH, NIDDK data science programs and, their support for AI-based precision medicine. The other important aspect, of this meeting is the breakout groups. So the breakout groups will be happening over both days. On the back of your badge, you should have a little colored sticker that tells you which breakout group you're in. And each breakout group will be dealing with all the topics. So don't worry, everyone will be discussing all the topics. And those topics include, the first topic is really going to focus on strategies for integrating multimodal data in AI-driven precision medicine. And then topic 2 is development of predictive models and identification of disease subtypes and chronic diseases like diabetes. So those are the 2 topics for today. Topics for tomorrow will consider, exploring ethical challenge, that are associated with AI and precision medicine. And the 4th topic is how to foster effective interdisciplinary collaboration amongst biomedical researchers, AI researchers. And then we have some useful information. Hopefully everyone has found the NIH guest network. The breakout groups, the green, orange, blue will be in this room on these 3 sets of desks. There is the purple breakout is going to happen in 11:21:25, which is if you exit and to the right, it's down the hallway there. And then the poster sessions is going to be straight across if you exit the room that is straight across right there. So again, I want to thank everyone for being here and look forward to, some good discussions.
Right. So it's now my distinct pleasure to introduce our first keynote speaker, Dr. Hoifung Poon. Dr. Poon is General Manager at Microsoft Health Futures and an affiliated faculty at the University of Washington Medical School. Many of us already know Dr. Poon is a prominent figure in artificial intelligence and biomedical research. His team has developed the tools and the models that help extract critical insights from biomedical literature. As one example, such as disease pathways, potential therapeutic targets, etc. In addition to his research, I want to also mention that Dr. Poon is widely recognized for his collaborations across academia and the industry, where he advocates for responsible and impactful AI in biomedicine. This is very relevant and important today, given the many significant gaps and the challenges in AI. We do believe a greater partnership between academia, government, and the industry is needed. So without further ado, Dr. Poon, thank you. Welcome.
Thanks so much. Can everyone hear me okay in the room and on the Zoom? Awesome. Awesome. I just want to do a time check because I think we start like 10 minutes late. Do I still have the 40 minutes or? Yes. Okay. Okay, cool. Very excited to be here and so great to see many friends and looking forward to making new ones. So I'm fundamentally a CS person, a computer science person, and so I'm sort of a lay person still in biomedicine. So looking forward to learning from all of you. So here I'm going to try to. At Microsoft Research, we have been kind of exploring advancing AI for precision health for over a decade. So here I mostly try to share some of our battle scars and some of our learning over the years. And again, looking forward to discussing and learning from all of you. So with this crowd, obviously, I don't need to delve into kind of precision health. I'm really preaching to the choir, right? So at Microsoft Research, that really sort of motivated us to start this kind of AI agenda. Essentially can be described as trying to learn sort of like holistic kind of patient embedding from population scale real world data. So that get us to essentially probing the cutting edge of the generative AI that's really happening in work right now. And there are a lot of the already kind of exciting kind of progress that can already help potentially transform and really accelerate progress in precision health. But there are also some of the really prominent kind of growth area, which I will give you some examples and some of our kind of like hypotheses right now, trying to tackle those challenges. And I will end with some kind of real world applications with large scale health systems and so forth. So obviously, like we are all here to sort of like, advancing precision health. In the ideal world, obviously, we want every patient to be able to respond to the treatment they have been prescribed to. So here in the graph on the left is signified by the blue person, right? Unfortunately, in the real world, oftentimes the patient do not respond to the treatment. That's signified by the red person. Now, obviously, there is a huge amount of waste and unnecessary suffering, but most important of all for patient, that's just a giant miss of treatment opportunity. A lot of work we have worked on is actually cancer, right? So, which is obviously the poster child for this problem. The first generation kind of cancer treatment usually adopt slash burn and poison, right? So toxicity is high, efficacy is low. Then came the sort of second gen of the targeted therapy. Apology a little bit about the imagery, but on the left you can see late stage melanoma patient, right? Nothing works. However, by identifying that the cancer is actually driven by this BRAF mutation and then specifically target the mutant protein domain, right? So you see in the middle, that is basically a dreamland of precision medicine, right? So the cancer melted away with almost no side effect. Now, cancer obviously is very robust. It has the blessing of natural selection. So ultimately, it kind of figure out ways to get around. So we are far from being done. So then came sort of like the really exciting cutting edge of the immunotherapy, right? So immune system is basically the one health system that also has a blessing of natural selection. So indeed, you will see some of the blockbuster kind of treatment like Keytruda, right? That actually were able to kind of work miracle on some of the late stage cancers, right? But still, on the grand scheme of things, if you look at overall response rate, it still hover around 20–30%, right? So again, we're still far from being done. So then, when standard of care doesn't work, right? So which unfortunately happen a lot of time in cancer, then the last hope for the patient is a clinical trial, right? So here is Martin Tannenbaum, who is a prominent AI researcher, but also very successful e-commerce entrepreneur. At the peak of his career, unfortunately, he got diagnosis with late-stage melanoma, right? So, but fortunately for Marty, he has a big network. He mobilized and to find a matching trial for him that saved his life, right? But if you look across the board, right, so most cancer patients are not as lucky, right, as Marty, right, obviously, and have as much resource, right? So only single-digit percentage of cancer patients were, even in the US, right, were able to find matching trial. And on the flip side, ironically, a big chunk of cancer trial failure is simply because they couldn't recruit enough patients in time, right? So obviously, with this crowd, I don't need to talk about how difficult, drug development is, right? And this problem is going to exacerbate even more in the precision medicine era because we need to develop more treatment, each targeting smaller population, right? So the dream here is that obviously, can we kind of like maximize of utilization of every single bits of health information, right? So this obviously long-standing dream about living sort of like learning health system that can incorporate all those information to optimize care on the one hand, but also accelerate discovery on the other hand, right? So one of the key underpinning is obviously the real world evidence, right? So if we think about it every day, there are literally billions and billions of data points collected in routine clinical care that documenting a patient journey from diagnosis to treatment to outcome, right? So at the beginning of the patient journey, even the best doctor may not know, actually have the perfect crystal ball to know what happened, right, in the patient journey. So each patient journey is almost like a mini trial, and each encounter offers some new information, right? So, and if we can actually distill all those insights, this will be a giant population scale free lunch, right? Now, obviously, there has been already a lot of exciting great works in, in RWE for decades, right? Like especially on like clinical, on structured EMR and so forth, right? One of the great opportunity is that we can actually go beyond those surface structured information because there is a lot of kind of like what I will loosely call kind of dark matters for real world evidence, right? That actually hidden beyond just those readily available structured data, right? So for example, here is one DID journey for a cancer patient. It's actually a very typical cancer journey, right? So each bar here is one clinical note for the patient, right? So you can see so many different node types. But also crucially, each node contains lots and lots of detail information that most of them often don't reflect it in the structured data, right? And beyond the clinical text, right, you also have an increasing array of information-rich modalities, right? So in a cancer patient journey, you start with non-invasive stuff like CT, MRIs, and so forth. Then once you get biopsies and recession, you start to get, for example, digital pathology, multi-omics, and these days there are all kinds of exciting like single cell stuff and so forth, right? So each of those modality is trying to tell you something about the patient, right? But each modality is also fundamentally limited, right? So only by kind of like combining all those modalities, then we can recapitulate sort of a holistic representation for the patient. And so from this point of view, right, we can sort of think about kind of like precision health from a machine learning point of view, right? Which is that basically we are simply trying to learn a function, right? And the function, the input is essentially all this multi-model journey about the patient, right? So all this information about patient. And what are we trying to do is essentially try to predict some of the really important medical events, right? So will the disease progress, right? Will the cancer relapse, right? And also all the counterfactual, right? So for example, what if we put the patient on a certain treatment, what will happen, right? So, if we can learn a function that with a very high accuracy, then we can make a big leap in precision health. Now, of course, it's not so easy, right? So a patient not just basically a single snapshot, right? There is a huge longitudinal journey here. More annoyingly, right? Most of those information actually are not available, right? So, and for the available observable information, there could be noise, there could be biases and so forth, but more importantly, there is also a lot of kind of cases, kind of timestamps or modalities that you don't observe, right? So that's actually where the generative model and the latest wave of generative AI become actually quite relevant, right? So one of the hallmark of the generative AI is this concept called generative models, right? So you can think about even, you know, graphical model, probabilistic models, and so forth. And one of the strengths for this kind of model is that they can allow you to model the joint distribution of all this kind of modality, time points, and so forth, right? And with this kind of joint distribution modeling, you could also be able to start to infer all those latent kind of like modality that you don't directly observe based on the observables, right? And then you can think about sort of like those really important kind of medical events that you really want to have a crystal ball for as basically a special case, right? And so from this point of view, right, you can think about drawing an analogy with GPT-4s and other kind of frontier models, right? So GPT and whatever famously is trying to predict the next token, right? So here you can think about a principal thing we are trying to do by learning from the real world data is essentially trying to predict next medical event, and so forth, right? So that can allow us to provide a readily available way to learn from the real world data, to learn from this longitudinal patient journey, but also it allows you to come up with this kind of model, right? Sort of like patient embedding that allow you to start to have a crystal ball to start predicting sort of the really important medical event that you really care about, right? So that's kind of like motivated us to start to pursue kind of this agenda where on one hand, we are trying to essentially starting from all those rich real world data, try to portray this kind of very powerful biomedical foundation models. Now, one of the really exciting thing about the Gen AI disruption is that when you think about the learning problem, machine learning problem here, right, is that you have a giant dimensionality, right? So you have many modality, heterogeneous, noise, and all the biases, and also giant dimension. But one thing that neural network is really good at is deal with dimension, right? So for the first time ever, we start to caught a glimpse of hope that we were able to potentially learn a very high fidelity kind of patient embedding that you can almost use it as like a digital twin for the patient, right? And if you can actually make some progress in this learning direction, then you can start to actually enable very powerful inference, right? So like, for example, in cancer, like once the diagnosis is done, oftentimes people go for like second opinion for opinion, right? But if we have this kind of real world evidence at hand, you can snap a finger, you can basically draw 5 million most similar patient, and then you can interrogate what happened to them, right? So what kind of treatment have been going on, what kind of journey they have been going on, right, and so forth. So you can immediately already help improve patient care, right? But on the flip side of that, you can also look at what about those exceptional responders? What about those 20% lucky folks, right, who take Keytruda? What about those 80% non-responders, and what are the differences? And by drawing those differences, you can start to potentially, number one, potentially improve a companion diagnosis, but then you can also potentially identify resistant mechanisms and so forth to kind of accelerate discovery. So some of you who work on large language model probably have heard about this kind of concept about emerging capability, right? So that basically is like, if you have a large capacity enough of model that learn from large enough data, then you can start to have this phase transition that they start to basically discover, sort of learn some, acquire some capability that initially you thought they could not do, right? So here, I think one of the interesting thought exercises as follows, right? Imagine tomorrow we have GPT-6 who read all the textbook, all the PubMed paper, 30 million of them, read all the guidelines and everything, right? So that really captured today's healthcare common sense. That's obviously already a very, very powerful medical brain, right? But still, I would argue that that's actually far from enough, right? Remember the first graph when today's medicine, even the best practicing one, still have so much growth area, right? So here, the hypothesis is that even lying in plain sight today, right, with all those like kind of like real world data and real world evidence, there could be a lot of insight that go beyond today's healthcare kind of common sense, which we may be able to uncover and sort of like the emerging capability. So that's kind of like sort of the whole kind of motivation for a lot of our agenda. Then obviously the question is that can the AI deliver, right? So obviously like last year, everybody is, many folks are trying to jump on the bandwagon for Gen AI, right? And this year, everybody start to have second guess, right? Like, are we overhyping, right? So here I'm trying to take a look at what's the kind of state of the union for Gen AI right now, right? So if you think about it, this is a fairly mature kind of typical kind of paradigm, how people are applying Gen AI today, right? Mostly on the text dimension, right? So you could use a frontier model like GPT-4, for example, directly, right? So prompting it to do stuff. And then if you have a very big kind of like repository that could not fit in the however many context window, right? Then you can say, let's try to incorporate RAG, which is retrieval augmented generation, right? So essentially you just retrieve some top K results and put them in the context, right? Rather than having to go through the entire repository. Now, if you also have certain tasks that you really, really care about, really, really mission critical, and you also have lots of supervised data, then you can also do fine tuning, right? So those are basically the three ways that today people have been using it. And now there has been a lot of truth in suspecting that we may be at the peak of the overhype cycle, right? So and there are actually lots of growth area. I wouldn't go into the detail, but happy to talk more offline. But I also want to highlight that there is often time where exactly at the peak of the hype cycle, right? So we set our expectations so high at the beginning, so we are bound to be disappointed for a little bit. But on the other hand, there is an undercurrent where actually there is profound transformation start happening, right? So here I would put forth some of the evidence of that transformation. So many of you probably let's see. Yeah. So I would say that. So I would say that one of the most immediate kind of like profound transformation that already bearing some fruit, which I will actually show in the next slide, right, is actually mostly on the left-hand side. So I will loosely call that productivity gain. So these are the routine where actually human experts are perfectly capable of doing those stuff, but they are just super boring, super repetitive. And for example, if you talk to a registrar, right, who has to curate for cancer registry, a single cancer patient, even curating basic information could take 2-3 hours, right? So multiply that by 2 million new cancer patients in the US alone every year. that's a really humongous effort, right? So, but these are exactly the area where actually the current Gen AI, even out of the box, and later I will show you some example, right? Even out of the box, they can actually be the sort of the errand person for the human expert, right? Do 90% of the really mundane work, right? Try to reduce the giant pile of haystack to some very small candidate needles. So then the human expert can just do it in a human in the loop to verify. And so that's already kind of like happening. But I would say that the moonshot is really on the right-hand side, which we are far, far away from actually being able to get to, right? Which is that we could even go beyond, discover something that even the best human expert, right, may not be able to grasp and uncover, right? So no human being can actually read all 30 million papers, obviously, right? So, or the, all those omics and imaging and data point. So there, the right-hand side are the area where we also caught a little bit glimpse of hope, but we are very, very far from we were just at the very beginning, right? So what are the things that today you can already do, especially in the productivity gain regime, right? So here I want to emphasize that there are some, the funny thing is that things progress so fast, right? So even 1 year feels like, over a decade, right? So when you think about just 7 years ago, actually transformer was invented, right? And then 6 years ago, the burr is invented, right? So that was kind of like a foundation for the first generation foundation model. So many of you probably are very familiar with. And we are very happy to publish lots of results about, hey, we can get 5% gain, 10% gain, 50% gain, right? But here I would emphasize that it's the latest Gen AI wave is even more profound because they actually point to a completely new way to do things, right? That are not just like you can fine tune with, a few percentage point, right? So one of the area I would give you some example is that what I would loosely call universal structuring. So basically it's like one of the big pain point is that all those patient information you saw earlier that hidden in those unstructured nodes, right? So, and the free text is still the most efficient way to capture a lot of the complex information. And right now the Gen AI get to a point where even out of the box, right? They can actually do a lot of those structuring in 80-20 fashion. So that will have huge ramification for the real-world evidence, serving as the foundation to extract those high-quality metadata, right, for everything. Then you have this model that can not just translating languages literally, right? So they can, right? So, but they can also translate cross ontologies. Right, so OMA, FIRE, they actually have very good understanding of what they are. You can ask them to go into each directions and so forth. So that have a very big implication on interop, right? Also, one of the mental model I often think about this frontier model is that they are basically a very smart, reasonably knowledge, kind of like, a system, right? So anything you can probably describe in a instruction for that kind of assistant to do, oftentimes they could do it, right? So that means that when you actually need to create new data set, need to create new benchmark, need to create evaluation, now there is a much more efficient way to do it, right? So that can actually make or break actually a project potential. Now, ultimately, I would say the most amazing capability that emerging, getting better and better, right? So some of you saw O1 recently, but actually even in the very first generation of GPT-4, you shouldn't treat them as the organ of truth, right? But they are very, very good reasoning. You can ask it to provide a train of thought, and they can give you very good reasoning train, and you can interrogate whether each link is correct, right? Some of the link may not be correct, so that's where hallucination happen. But still, overall, the reasoning capability, you can harness that, and ultimately, you can imagine that you basically say, I want to talk to this messy, noisy data, right? So you can already start to doing some of that. So, so let me first illustrate some example on the text modality, right? So, some of you might be familiar with the map prompt, right? So essentially, this is a 2-week hackathon and Microsoft research. We are trying to see, hey, how good can GPT-4 out of the box do in the US MLE entrance exam, right? So, and turns out that we are all actually get surprised by how good it can do, right? So this is first time we can hit 90%. But more importantly is that for a whole host of biomed NLP tasks, it can also do very, very well. Out of box again, right? So emphasizing that the model you don't need to fine tune it, you don't need to do very sophisticated stuff, and out of the box you can do it. So that means like actually on the text modality, even for biomedical text, right? This is sort of maybe one underappreciated fact is that the generic frontier model are actually very good at biomedical text, right? And when you think about it, it may seem a little bit paradoxical, but when you think more about it, it's actually very obvious, right? Because you look at the public web, you have 30 million PubMed paper already, right? You have gazillion of web pages like WebMDs and so forth, gazillion of podcasts talking about biomedicines and so forth. So all this frontier model already consume all of those stuff, right? So that's why it has a very good, like close to human level understanding of those texts and close to human level of reasoning of those texts, right? And also even implicitly capturing a lot of those kind of knowledge, right? So this is great, right? So so let me give you some example why this could have a big ramification on precision health. So think about the kind of like the clinical trial matching case, right? One of the challenges that for each trial, you have all this elaborate inclusion, exclusion criteria for what the trial is looking for, right? However, you can basically just, again, simply talk to the GPT-4 with very natural instruction. They can actually parse those elaborate kind of like trial logic for you, right? So, so that's great, right? So you basically can using it to figure out what the trial is looking. Now, of course, many of you have actually did amazing work on this space. You know that actually the difficulty is actually on the patient side, right? So you can always, farmer can always afford to structure the trial, but with those 2 million new patients every year, that's a new challenges, right? So but in this place, again, the GPT-4 or other frontier models, right, can also out of the box extract a lot of those key information, and at an actually sufficiently high level, right? High accuracy level, right? So I want to particularly using an example of clinical staging. But for cancer, that's a particular challenging, right? So you have this 600-page AJCC book, right? So it's every single cancer type, what are you looking for? And this could be 1B, this could be 2A. And also annoyingly, right? I think this is already 10th edition, right? So maybe December 31st, this cancer will be classified 1B, and then January 1st, this will be 2A. That's a nightmare for machine learning system, right? So, but actually with this kind of frontier model, you can basically ask it to literally read the freaking manual, right? So you can say, hey, here's the addition I want, right? And here's the instruction, you put them in the context. You basically put the patient notes also in the context and say, follow the instruction. So we actually have one particular example where we work with our collaborator initially, right? Spend some sweat and tears using first generation BERT models, right? To try to get this thing right. We got to the SOTA state-of-the-art result, but still lots of growth area because like, you know, numerical understanding, but also more importantly, all those kind of semantic shift, right? Based on the version. Surprisingly, we basically used this out-of-the-box approach. Even with zero shot, we were able to get to a very kind of comparable accuracy. So that basically hinted at sort of like a potential way that you can scale all this curation. And I know many of you actually have like Zhiyong and Jimeng have done also amazing work here, right? So so here, because of all this, right? So literally, there has been a serious discussion to say, hey, should we wait for GPT, 6 or 7 or 500 to solve all this problem, right? So, and what we observe is that actually, number one, once you go beyond text, right? Once you go to non-text modality, right? Medical imaging, multi-omics, that's when this frontier models start to expose their competency gap, right? And when you think about it, it's not surprising because once you go to the non-text modality, there isn't that much of the multimodal longitudinal patient data in the public web, right? So hopefully not, right? So and here, for example, just a visual example, right? So if you ask some of this frontier model, what is the lung CT scan they use to very happily give you a glowing lung. These days, they are much more tactful. They would say, hey, I'm actually don't know what I'm doing, so maybe I will give you some illustration or something, right? So, but this also actually is a visualization of a much bigger problem behind the scene, which is like, once you go to all those kind of modality, right, then you have a giant competency gap here. So more importantly is that besides from all those modality, right, individual modality, there is also how do you combine all those modalities, right? So, so let me first give you a very quick example about digital pathology as an example for some of the individual modality. Many of you probably know way better than I do, right? So we care about digital pathology because it tells you a lot about tumor microenvironment. For example, like tumor infiltrated lymphocyte, that will potentially give you some hint about whether the tumor is hot or cold, whether it will respond to immunotherapies, right? So, but all these things require you to actually model not just a single, local patch, right, small patch, but you actually have to model the entire kind of like, tumor and immune cells and also all that, right? Now, nominally, we have exactly the powerful tool to do that, which is transformer. One thing you can think about transformer, what it's doing in digital pathology is like, it basically try to get every pixel to talk to every single other pixel, right? They basically try to exchange information. That's literally what transformer is trying to do, right? So by doing that, you actually are able to capture arbitrary complex patterns among that. But there is an Achilles heel for transformer because you have to model every pair of pixel. That means like computationally, it will scale quadratically to the number of pixels, right? So digital pathology, unfortunately, have the most biggest images, right? So just to put it in context, right? You grab some web images, right? You thought they are big, but compared to digital pathology, right? It could be hundreds of thousands of times larger, which means that computationally it could be billions of times larger, right? So I wouldn't try to go into too much detail, but just try to give you a glimpse of the idea. So essentially, instead of having every pixel to talk to every single other pixel, right? You can do that locally, first of all, if you do it in a very small local region that doesn't kill you, right? So that you can afford the quadratic growth there. But once you go to bigger and bigger segment, that's when the quadratics start to kill you, right? So, but what you can do is that if the local neighborhood, right? The pixel are already exchange signal enough within the local, then when you go to having a local neighborhood talk to another neighborhood far away, right? You don't really need to have every single pixels exchange information. You can elect some representative in the neighborhood, right? And then have them to basically exchange the information. So that's exactly what this dilated attention idea is about. You can elect the representative at the sparsity that is proportional to the segment size, and thereby you cancel out the quadratic growth, right? So anyway, so we are very lucky to have collaborator with Providence, a very large health system, and University of Washington. This work recently is published by Nature, and I wouldn't have time to go into the detail. Very excited to see a lot of the interest in the community. But let me just quickly tell you sort of like in the grand scheme of thing about the multimodal angle, right? So what the GigaPath and the digital pathology exercise, what we are trying to do is that for any modality, when you have the unannotated data, right? Let's say unannotated images, usually you have a ton of them, right? So what you do is that you are basically forcing it to learn a pair of encoder and decoder to try to recapitulate the original image. So you can basically generate infinite data by however many of the unannotated data you have, right? And then there is a special case, which is the text domain you can already do. But the challenge is that once you learn individual modality, right? So you have a CT scan, maybe learning about what a tumor lesion is, but it's putting in somewhere in the embedding space, right? Whereas the digital pathology may be capturing the same concept in somewhere else, right? So that's basically become a giant kind of translation problem, right? So it's almost like the real world translation problem where you have hundreds of languages, right? And every single person is trying to tell you something, but you don't know what they're talking about. So here, when you think about sort of like the machine translation world, how they solve this problem is by introducing this concept called interlingua. So basically a resource-rich language, let's say English, right? And then you using that, let's say you translate a language from Africa to English, then you translate from English to some sub-language in India, right? So that's how commercial machine translation systems scale to the thousands of languages in the world. So what we are proposing here is to do the same thing, right? But using text modality as the candidate interlingua, right? And then, so we basically then focusing on, okay, we already did a lot of hard work, burn a lot of GPU to learn those encoder decoder, right? So we keep them as is. And we're focusing on learning this very lightweight adapter for each modality to map them into the text modality, right? So in this way, then we can allow, once we learn all those modality specific adapter, then all the modality, we can put them in this common text semantic space to reason about, right? So I don't have time to go through all the detail. I want to highlight one example, LavaMed, and happy to talk more about offline, because this is basically illustrating one general recipe, how you can do that. And you essentially, you can, we have proof point to show that you can also apply that to, for example, pair modality text data in the patient journey, right? So for radiology, for pathologies, and so forth. You can also augment this scheme by to do image generation. So you can do counterfactual image generation, right? So for example, given a chest ray, you take six months ago, you said, hey, what happened? What if the patient had this progression? What would the image look like, right? So we got some preliminary result here. You can change the image generator to mass decoder, which means that you can actually do natural language-based segmentation, right? So you can talk to the system to ask it to basically, hey, segment the tumor for me, segment organs, segment all those kind of biomedical objects and so forth. So I would say there is lots and lots of growth area, right? But at the end of the day, we can think about everything can be thought as embedding, right? To some extent, right? So patient can be embedded, but you can also do the same thing for drug and other intervention, right? So then at the end of the day, you can think about it as that we are just playing an embedding calculus, right? In the clinical trial space, you can already do that, right? So we have some great collaboration with Providence, which is a large system in the West Coast. And they already put them in some test sites and thousands of patients a year. I want to highlight that actually this is just the beginning, right? So clinical trial matching is very important in its own right. But once you can do this, what you can do is that you can snap a finger, you can conjure up a virtual case arm and virtual control arm for any research hypothesis you can formulate as a trial, right? So what that means is that you can basically get a population scale free lunch to do hypothesis generation and testing. So in particular, you can say, hey, I have this real world data for Keytruda. Let's say, for example, this is the original Keytruda trial, right? So can we look at the real world data? Can we actually get the same signal comparable to the trial that the farmers spend hundreds of millions of dollars to gather those data points, right? So indeed, like here are some of the marquee lung cancer trial. We find that with our Providence collaborator, it seems like we can actually get a lot of those signals from the real world data. So obviously there is lots of caveat about confounders and other stuff, right? So I'm happy to talk more in the detail. I just want to end on a sober note. This is one de-identified patient journey, right? So at the beginning, got CT chest ray, then got PETs and so forth, right? Get MRI to see whether metastasis, then start the treatment, right? So, and within 2 weeks, you have so many modalities happening, right? So the patient, the cancer is on remission for a while, looks good, but then after a while, suddenly the patient start feel some problem with the lung, right? So they do chest ray, do MRI, nothing happened. Then they do ultrasound, unfortunately, they detect the metastasis, right? Within a month, then the patient died, right? So this unfortunately is happen too often, right? So the question is that, can we do much, much better? So I want to acknowledge my team who do all this work, and also obviously we can't do any of this without our collaborators. So thank you.
Thank you for the wonderful, inspiring talk. We have a few minutes for, I guess, a few questions. Please come to one of the microphones in the room.
First of all, great talk. So this is Wei-Qi from Medical. So I'm wondering, when you talk about patient embedding, are you talking about the patient embedding embedding regarding it. Are you talking about the particular patient episode, or you're talking about general EHR?
So I'm thinking about, great question. So I'm talking about essentially it's like conditioning on everything that we observe, right? What?
If you're talking about inpatient, that's pretty straightforward. That's
You're thinking about the outside of the clinical system.
Right,
Yeah. Yes.
The problem is like you only have the patient 5 years.
Yes.
Yes. Blood pressure. How can you predict?
Absolutely.
What happened in the next 10 years? Or what happened?
Absolutely. Yeah. I think the mic may not be on.
Sorry.
But anyway, this is a great question, which is asking about, so far, I basically have been focusing on the clinical footprint, right? So this is okay, 80-20 okay for some high touch disease like late stage cancer, right? But once you go to early detection, once you go more and more into health, right? And also when you think about like mental health, metabolism disease, and most of the footprint actually is outside of the clinical, right? That's so absolutely. So right now we are starting from the clinical footprint, but what we hope is that eventually you get to like patient-centric, care, then a lot of those kind of social epigenetic data can somehow be captured, digitized, and we're able to actually add to this, right?
Second question is about you haven't talked about is regarding the genetic side. Genetic side is for precision medicine. That's basically the core.
Sorry, what?
Genetic side.
Genetic, you're right.
Right. So right now we have, like we're talking about the millions of, even like a zillions, billions of features talking about the SNPs.
Yeah.
So, but the patient growing actually is slow.
Yeah.
So I'm just wondering, what's your comments regarding leveraging AI power for more?
Absolutely. In fact, the over decades ago, I pretty much know nothing about biomed, but the reason I started with cancer is that was a 10-year anniversary of Human Genome Project, right? So and that completely revolutionized how we think about cancer and everything, right? So I would say there are already lots of emerging kind of work. In fact, I don't have time to go to, but happy to talk offline. Even in that Nature paper, we were basically trying to look at correlation, for example, like how would the H&E slide, do we have any morphology signature for example, perturbation to genetic mutation? We discovered some pan-cancer signature, like for example, for KRAS that our pathology collaborators have no idea about, right? So that's really exciting, really scary, but really exciting. And also you start to have lots of single cell stuff, right? Like multiplex protein, but also spatial transcriptomics. So we definitely are looking into that.
So here, great talk. So my question is more about operational aspect of implementing this multimodal data. Let's imagine that you're actually doing some embedding and making some recommendations, and then you're adding an additional modality. Embedding may change, updating your algorithm, your embedding changes. The algorithm changes as we see today, changes on a daily basis, but the patient enrolled in clinical trials cannot actually change due to regulatory constraints and the way that we do business. How do we resolve that?
Yeah, great question. Like, I think there are two parts of the question, right? So one is like, if you look at how clinical trial we are structuring the IE, right? The inclusion exclusion criteria, they're mostly sort of like the kind of very discrete categories, right? So there could be a potential at the end of the day to actually switch that to more complex biomarker, like could be more high dimension representation. But the drawback is like they are less interpretable, right? So you can say today my IE is like, okay, here's the prior treatment, here's the A, B, C, and D, right? Tomorrow, if we just have this embedding, how can we kind of interpret it? I think there is a lot of great discussion we can have there. I think another part that what you're talking about could be sort of the adaptive nature, right? So I think the adaptive nature could also have two different parts of it. One is like during the learning phase, right? In machine learning, you usually have two phases. One is like the learning phase, the top direction, right? So you are learning the model to actually learn to how model all those modalities and so forth to come up with a representation, right? There are the inference phase, which is that conditioning, you already learned this model. How do you interpret every single incoming information, right? So I think in the inference phase, there is a pretty well standard paradigm, for example, like the Bayesian update paradigm, where if you get new information, you can do Bayesian update, right? So I think there is, in principle, there is machine learning way to do that. But on the other hand, this also means that you have this kind of like actively changing, adaptive but also high dimension representation for patient. And I think there is a lot of kind of work to be done to think about in regulatory perspective, how do we regulate this kind of stuff, right? So I don't know whether I capture your question properly.
Not quite, but then I think if you put a patient on a drug trial X,
Yeah.
and then if your algorithm changes in the future,
Yeah.
you cannot literally change the drug Y to the patient in the middle of the trial. That's the problem. Our algorithm or modality changes, it's not perfect. How do we adjust it to the actual operational aspect of patient treatment?
So my understanding obviously are very shallow, and that's why I love to learn from all of you, right? But one thing I learned, at least my impression today, is that you model that as almost a medical device. You said, hey, let me frozen the model, right? So you could imagining, I don't touch the model, but the hallmark for machine learning is that it can improve, like you said, with more data and so forth. So the model should over time get evolved, but then it brings all sorts of machine learning challenges, like how do you know that the new model is better than the old one? How do you adjust for the trial when, but I would say fundamentally top of mind, it's not that different from, like, let's say your old trial using a set of IE, and then after a few years, you learn that actually there is some other attribute, right, that you should incorporate, right? Just in the old days, you incorporate them as a discrete IE criteria, but now you may be incorporating the data. So I think there is a part that are similar to today's landscape, but there are some new challenges.
Do we still have time, or?
Maybe Sala and Paulina, if you don't mind making your question quick.
Quick question. I really enjoyed your part of talk about digital pathology and the concept around encoder, decoder, and adapter related to H&E slides. So what are your thoughts about how would this work for images, whole slide images, where you have maybe 50, 60, 70 cell-specific markers? How would that model, would that be adaptable to images like that?
You mean like this will be IHC, multiplex IHC?
It would be visualization, say, by fluorescence, not bright field, right? But you would have 60, 70 markers on a slide, and you know, how does encoder, decoder, and adapter gonna work on a slide like that?
Absolutely. I think in principle, you can apply the same way. In fact, there are already some folks that I can talk more offline that actually apply our GigaPath model, adapt to, let's say, multiplex or spatial transcriptomic. We are also doing some of those kind of virtual staining work. So love to like pick your brain. Yeah.
Quick question, please.
Okay, quick question. Polina Kukhureva from University of Utah. I'm wondering about computational resources required for this. So do you think universities can do this type research on their own, or do they have to collaborate with big tech like Microsoft to complete this training on transformer models on multimodal data?
Yes, so I think one of the promise for this kind of so-called foundation model is that you basically train on kind of like really large scale of data, right? So that's when you burn most of the CPU, the GPU, right? But once you trained it, then you can build on top of it, right? So for example, like I showed a little bit earlier, the beauty for the GPT-4, which is a paradigm shift, is because in the old days, once you get a BERT model, right? If you want to do some specific task, you still need to do task-specific fine-tuning, right? You still need to collect the supervised data. You may collect fewer, but you still need to do all those stuff. But out of the box, right now, this frontier model can already do a lot of those things for you. So that can drastically lower the computation, right? And the inference cost, they'll keep having technology breakthrough that actually make the inference costs lower and lower and lower, right? And also likewise, like for example, that's why we are very kind of like strong proponent of like kind of like make all those model open ways and so forth. Like GigaPath has already been downloaded over close to 400,000 times. So we are actually really excited that if we can contribute to the community.
Thank you.
Thank you. Let's thank all of them. Just have a very quick information before the break. Because of federal agency policy, we cannot offer coffee to everyone. But however, to our invitees, the speakers and the co-moderators, we prepared some coffee pots in the kitchen. And there are 4 K-cup machines. So I'm sorry, we cannot open it up to all attendees at this time. And then let's catch up time a bit and let's try to come back 9:45 to start the next session.
Okay, so now we get started. My name is Wei Wang. I'm from UCLA. So let me introduce my co-chair, Professor Carl Young from Emory University, and he's assistant professor at Emory. He's trained in computer science, but now he's devoted to AI for medicine. Actually, this is a young star, and please talk to him during the break and afterwards. So he has done excellent research. Last week he just did a wonderful talk to CFDE on the knowledge graph and how that used in advanced medicine. So today we're going to, actually for this section, we're going to co-chair this. For this session, we have 4 excellent speakers, and each of them going to use 15 minutes to share with the audience their latest research. And after that, we'll have a panel discussion. So we will hold all the questions until all the presentations are done. Okay. So the first presenter is Professor Tina Hernandez-Boussard from Stanford University, and she's the Associate Dean of Research and the Professor of Medicine. So without further delaying, I'm going to invite Tina to the podium and to give her presentation.
All right, good morning. Can you hear me okay? Perfect. So thank you so much for the opportunity to come and speak with you today. Thank you to the organizers. I think that today we know that we can't have conversations about AI and health without really thinking about bias and equity and how they affect all different populations. So I'm coming to you from 2 different hats. One, as Associate Dean of Research, I work on developing the infrastructure at Stanford University for all researchers to think about how do we really move our innovations and our technologies to point of care. And then also as a professor where I have a group of students where we really think about the application of AI in healthcare. So okay, so let's get started. So we know, right, there's AI is growing across clinical medicine. We heard a lot about multimodal data in the previous talk. There's evolving technologies that really are outperforming anything we've seen before. And in addition, there's stakeholder adoption, not only from healthcare systems and clinicians, but also patients, right? Patients are starting to use technology. They're starting to come with their own printed data to clinicians. And so this has been really changing the way AI's role in clinical medicine. But we know that there's this hype, right? And I'm sure you guys have seen this scale before. And I don't know if I have a pointer, but do I have a pointer? No, but we're kind of at the hype right now. We're at that very tip of the curve for AI in medicine. And we're so excited about, the potential opportunities. But then what really happens is there is this falling of the hype where we actually don't see the potential. Gosh, I did. Technology. See, this is the downside of the hype, right? Okay, thanks. But really what's been happening is we're trying to use these tools and we're so excited about the hype and the promise and bright, shiny objects that we forget about, this is really about improving patient outcomes. And so, I heard this great analogy, we don't use a chainsaw to cut grass. And the same way we have to think about all these AI tools that are coming into medicine. What is really their opportunity for efficiency, for improving patient outcomes, and how do we think about that, right? And more recently, there's been a lot of concerns, ethical concerns about AI in healthcare, right? Because we know that AI can make mistakes, right? So we might have a really easy time distinguishing between parrots and guacamole, but AI sometimes has a real challenge in distinguishing between these types of classification models. We also know that AI is biased, right? This was a good example where Barack Obama was given to a generative AI tool and he came back out as a white Barack Obama, right? And we also know that there are biases in the data that we feed these models. And so AI learns these biases in the healthcare system. So this is really important for us to think about when we start developing these tools and all this hype. How do we really bring them safely to point of care? So we've been thinking about really taking a step back and thinking about the holistic view of the AI lifecycle, right? So it's not just about model development and model evaluation. It's about how is the data created? Are we looking at data from an EHR, from a healthcare system, an academic healthcare system, using that EHR data? And then we have to think about, well, who has access to that healthcare system? And more importantly, who doesn't? So who does the data represent? Then there's data acquisition, right? What are my limiting factors from IRB, right? What can I include or not include? How do I have to aggregate data? And what does that mean when I'm trying to understand the biases in these data? At Stanford, we don't have a lot of Native Americans in our healthcare system. So I'm always aggregating that population with other populations. So what does that mean when I'm trying to understand how these models affect that population? There's a lot of emphasis on model development and model evaluation, and there's not a lot about model deployment. How do these models really affect patients at the bedside, clinicians at the bedside, societal impacts? And so again, there's a lot of emphasis on the hype, on model evaluation, about having the best ROC curve, about having the best accuracy, about having the best performance of the model, without really thinking about the societal impacts and how it really affects care delivery, and really bringing it back to patient outcomes. And so we also know that there's been health AI has caused societal harm and really broken down the trust, right? We've seen discrimination during COVID, where some of the initial AI tools that were developed really discriminated against vulnerable populations, right? Taking into account things such as existing chronic diseases, obesity, things like that in resource allocation. We've seen ED triage tools that have really been developed to tailor heart attack symptoms in men. And so they're not very accurate in women because these symptoms differ, right? And when we use retrospective data, for example, our past clinical trials, we know those were predominantly men. So training models on those data really introduce those biases into the models we've created. We've seen similar things with AI in dermatology, where it works very well for fair-skinned patients and not so well on darker-skinned patients, so accuracy really plummets. And this isn't just about race and ethnicity, right? We've seen other studies where there's proxies for cost and how we think about that. So a lot of AI models have really caused societal harm. And this breaks down the trust in the system, right? It breaks down the trust of patients. It breaks down the trust of clinicians. So how do we think about that, right? And so recently we've published this framework looking at guiding principles of responsible AI. And we said there's really 5 guiding principles when developing and using AI responsibly. The first is that when we develop these systems, they have to promote health and healthcare equity. We need to ensure they're transparent and explainable so that we can go back and understand what data was used or not used. How do they, what was the split? What were the assumptions in the model? We need to engage patients and communities to earn trustworthiness, to build back that trust that we have been chipping away at. There's also a really need to identify fairness issues and trade-offs, right? So when we start thinking about equitable AI and fairness, it's a balance, right? Sometimes we take a hit in accuracy to really make that model more equitable. So how do we think about that? And finally, encouraging accountability, right? Who's responsible when a model fails? Is it the developer? Is it the healthcare system? Is it the clinician who uses the model? So all of these are really things we need to think about, and we don't have clear answers for a lot of these, but I want to walk you through how we've been thinking about these different points. First is AI to promote health equity, right? So we've been really thinking about how do we develop these tools to understand health equity? And this is some work done with my colleague Fatima Rodriguez, who's a cardiologist at Stanford. And we're really using AI to understand what are some of the, how can we start understanding the disparities in healthcare? So here, for example, we used AI to identify clusters for statin-related topics in Reddit discussion. So really trying to get outside of the healthcare system to understand what are patients saying outside of the healthcare system. And we found that some of the key clusters for reasons associated with statins were things like, statin adverse effects, statin hesitancy, clinical trial appraisals. So it's really important to understand what are patients thinking, or not patients, these are our individuals thinking regarding statins, so that we can start thinking about how do we address these false pretenses, hesitancy or pharmaceutical biases, statins, et cetera. We also then use AI to go in, also with Dr. Rodriguez, to understand, well, when we look in our EHR system, why aren't people being prescribed statins when they meet guideline criteria? And so we found that in our healthcare systems, nearly 2 in 5 patients lack guideline-directed statin prescriptions. So patients who should have been on statins, these are in diabetic patients, they weren't on statins. And we also found that women and patients with non-coronary vascular diseases were less likely to receive statin prescriptions. And some of the reasons we pulled out of the clinical notes were things such as, intolerant of low-dose statins. Other side effects were noted in the clinical notes, patient declines, but also there was a lot of clinical inertia, right? We'll deal with this next time. The next clinician will deal with this, or, and also some perceived lipid control, so not really sure of the guidelines. So big opportunities for us to think about how we can use AI to identify some disparities in statin receiving, and really use AI for positive impact on dealing with disparities. The next point is in transparent and explainable AI. And so earlier this year, we did a workshop at NIH on transparency and explainability. And so we know that transparency fosters trust, accountability, and standards. And so in this 2-day workshop, we really were working through what are the barriers for transparency in AI and how do we move those forward. We identified 5 key building capacities for responsible AI and transparency. There was a lot of conversations about IRB and expanding IRB capacities to cover AI-specific ethics. Developing training programs on AI's ethical, societal, and transparental needs. Establishing incentives, right, for comprehensive documentation. When we're building models using data sets, there's no incentive to describe these in detail so that we can better use and reuse these models in a responsible way. And also creating incident databases to talk about proxy variables, which are variables we often use because they're more accessible, such as race. We know race is a social construct, but it's often used in a lot of these AI models. And I also want to just bring your awareness to there's competing definitions of fairness. So when we talk about fairness and AI and fairness, right, there's 3 definitions that are being used, and most people focus on group fairness, which ensures that algorithms treat different groups similarly. And so the approach here is to use discrimination statistics, for example, parity, demographic parity, equal odds ratio. But this there's no consensus on which is the right notion of fairness to use, because individual fairness is just as important. And individual fairness says that you're going to treat similar patients similarly. And so how we do that and how we measure that is more complex. It's harder to interpret. So we see, less use of individual fairness. And finally, there's counterfactual fairness, which ensures that an algorithm would give the same output if a patient changed groups, right? So if you're saying a Hispanic patient has an accuracy of 0.85, if I say, okay, let's just change the race or ethnicity of that patient, do we have the same output from the algorithm? So because there's no clear consensus, I think it's really important that we understand the trade-offs between bias and fairness. So we've been doing a lot of work to think about how do we evaluate models and their fairness, right? Looking at an evaluation, looking at performance parity, looking at sensitive attribute use. Also, there's this moving initiative to dismantle race-based medicine, right? And we're removing race from a lot of these AI algorithms where there's no causal association. And finally, navigating this fairness for AI in health, which is what I mentioned, are you interested in group fairness or individual fairness? And how do we bring those two notions together? We've also been working on bias mitigation strategies, and there's so much work in the field right now emerging in mitigation strategies, from thinking about individual fairness and censorship, to thinking about contrastive learning. So how do we pull apart different protected attribute, different synthetic data, perhaps, to augment the number of individuals we have in our models? And then also understanding protected attributes and how they contribute to model fairness. And so I'm running out of time, so I'm just going to quickly go through these last 2 points. A big point is engaging patients and trustworthiness, right? So we really need to validate having patients engage throughout the AI lifecycle so that they can validate reasons and co-design solutions. So we've been thinking about this again in our work with statin use and unuse, and understanding potential patient problems for not taking statins, right? Is it distance from healthcare system? Is it poor health literacy? Is it fear of side effects? And we've seen these themes come out in our Reddit studies. And so now we're bringing them to patient focus groups to really understand how these effects are real and important to patients. We've been doing some work using the All of Us data set, looking at percent days covered for statin use in diabetics. And we see real differences in the number of days covered. And so what we really want to know is really, why do patients hate statins? Why do they not want to take statins? And so, or GLP-1 receptors. So we're really trying to use different types of data modalities to get information outside of the healthcare system. And this was just perceptions of GLP-1 from Reddit, and how we can see the themes of conversations clustered in Reddit, right? They're talking about diets, they're talking about losing weight, they're talking about a lot of positive things on Reddit. And so we could take that home and really understand how we bring that into the models we're developing, into the application of models in healthcare systems. So going back to these 5 guiding principles for responsible AI, I think it's really important that we look across these guiding principles and across the AI lifecycle to understand what's going on when we're applying AI to healthcare. And importantly, the Federal Registry has picked up this work and said that, when you're developing these AI technologies for health, you have to ensure that you're monitoring them for potential impacts and discriminatory information, right, for decision making. So it's really important that when we're bringing these models, that we don't just think about developing the most accurate and the most highly performing model, but we think about how it has a societal effect, how it has a clinical effect, et cetera, and really bringing it back to improving patient outcomes, right? The whole point of AI in medicine is that it improves patient outcomes. It's not about developing the most shiny, bright AI tool, right? It's how is it really impacting patient care, transforming care through precision medicine, and enhancing access to care. So with that, I will thank you. I have so many people to thank. We have a great group, and I will take questions after the next conversation. So thank you so much.
Okay. Thank you, Tina. Thank you for the very informative talk. I know 15 minutes is hard. Next, we'll have Dr. Zhiyong Lu. Dr. Lu is a senior investigator at NIH NLM, and he conducts a lot of frontier research on AI and NLP, especially in biomedical text analysis and image analysis. I see his papers everywhere, and he really works a lot with both academia and industry, with a lot of people I know and I don't know yet. So without further ado, let's have Dr. Lu to say what he has for us for the 15 minutes.
Well, thank you very much for the opportunity to share with you some of our recent work. As introduced, I'm part of the National Library of Medicine, part of the National NIH Intramural Research Program, where I lead a research group doing AI and machine learning research for both biomedical text and image processing. So on a routine basis, we primarily working with millions of scientific literature in PubMed Central. When access is given, we also directly working on patient data, including both electronic medical records as well as patient images, specifically in the fields of radiology and ophthalmology, because we have great clinical collaborators on the NIH campus. So using AI and machine learning, we work on a range of different problems, including improving information access for the biomedical literature, which is very tied to the mission of the National Library of Medicine and NIH. But beyond that, we are also interested developing tools to extract information from unstructured text and to turning that into structured knowledge. And last but not least, we're interested in AI and large language model these days for healthcare applications. So for the 15 minutes, I'll try to briefly touch on some of these areas. But I will start with PubMed because this is perhaps something everybody is familiar with, and everybody's contributing to that because you are most likely you are the authors and you have papers in PubMed. And that becomes your contribution. Every year we see more than 1 million articles adding to PubMed, and now we have over, this slide is always updated, so we have now over 37 million articles. And on average day, we have about 2.5 million users. They're doing about 3 million searches and 9 million page views. So this, nothing compares to Google, but this does make PubMed one of the top used US federal government websites. So even though AI and machine learning is a very hot topic these days, but since day one, I've been at NIH, which is about 17, 18 years ago now, we've always trying to develop computational method trying to improve user search, user experience with PubMed. So here is a list of some of the search features you may be familiar with, you may be using when you're dealing with PubMed. One thing different from commercial search engine is that we trying to be very transparent to our users. We wrote papers pretty much for every tools that we developed, as well as white papers like the perspective papers describing how we actually using computational tools to make these available behind the scene and how our users are responding to these different search features. So, but as much as I love PubMed these days, the problem is not you don't have papers to read. You know, PubMed is a keyword-based search system. You're putting a keyword 3 or 4 words. Oftentimes, you are returned with hundreds, thousands, tens of thousands of paper back. Okay. The problem is for individual researchers, including myself, we just don't have the time to read all these papers, not to mention to make the connections. So the million-dollar question is, can we actually somewhat teach computers to read, to scan the papers? And just like the human scientists, and then they can potentially make the connections that would drive the discovery and pop up new hypotheses. So that was the problem we are trying to attack. And towards that goal, we have done some baby steps. We're trying to teach computers to recognize what is a gene name in the paper, what is a disease, what is a drug name, and what is the relationship between a drug and the disease. Is this drug treating a disease, or is just drug chemical causing a disease? So thanks to two very talented group members and scientists in my group, over the years, we have developed a number of different tools. We call these taggers to tag in what is a gene name in the article, what is a disease name in the article. You know, we cover a number of different categories because these are the most often sought concepts in PubMed search. As you can see, we started more than 10 years ago now, and a lot of these tools have gone through multiple iterations. And these tools have been developed using transformer models, but certainly before the era of large language model like ChatGPT. So you may wonder, why don't we just give, you know, through this abstract to ChatGPT and ask ChatGPT, what is the gene name here? Well, we've done that. You know, we have a paper forthcoming and comparing head-to-head comparison between the taggers we developed earlier versus ChatGPT. And to fair comparison, these taggers we developed previously still have a edge over the ChatGPT. Now, to be fair, this is because we had training data to make this happen, okay? So another things we find is that people are, because we believe open science, so everything we developed, we make that into public domain. So a lot of people, users, we find is they download these taggers, and then what they do next is they apply these taggers to millions of articles. So we thought, why don't we just do this for our users? Because number one, not every group has these resources to do things. Number two, there are people especially in biology or bioinformatics, they don't necessarily have the resources or expertise to run these computational tools. So that was the idea we created called PubTater, where basically we apply our taggers we developed and then to the entire set of 30+ million articles in PubMed, and then aggregate the results in the backend and render the results to the front end. So as long as a user have access to a internet and browser, they'll see the results right away. Now, of course, seeing is believing, and also this is not perfect. But guess what? If we ask two biologists or to anybody, two scientists to annotate the same abstract, they're not going to agree on the genes. And I can assure you about that. So this, even though this is imperfect results, that doesn't mean this is useless. And in fact, it's the opposite. You know, when we provided our tools through APIs, we have found that over the years, we have now a large number of users from a variety of different institutes and different geographic locations. And for APIs, we have over 1 billion requests. And because of that demand, we have actually continuously building on improving PubTater. So we started with PubTater in 2012. You know, we making it available through FTP APIs. And in 2018, we make About Move, because in the original PubTater, we only text my knowledge in the abstract, you know, without touching the full text, because full text is more complex. But in 2018, we decided it's time to do the full text. And 2019, with the transformer model, we used the latest AI tools to improve the performance. And in 2023, eventually, we also added not only the annotation of the concepts, but also the relations. So this is what we can offer today. So given an abstract or given an article, you see here, you have the disease, you have the gene, you have the mutation. We would annotate these, highlight these, and then not only just recognize these are the entities, but also standardize these entities to control vocabulary terminologies, and then putting that into a structured table, and everybody can have access to this. Now, you may notice that we made a move from abstract to full text, but we didn't do supplementary materials, because as you can imagine, all kinds of files can be dumped into supplementary materials, from images to tables to spreadsheets to PDFs to Word files. So it's very noisy and very difficult to do that right. But we've also repeatedly requested by users, they ought to do that at least for one entity, which is the variant. And that's what we did. We actually text mined, going one more step to text mine the information from the supplementary materials for variants. So we have built a spin-off of PubTater we call LitVar, which is tracking the variant information from the scientific literature. And our users are absolutely correct. Once we do that, we find the content size has increased multiple folds. So you can search for the variant, and you can also search it for a relevant disease or relevant gene in the second box. And this has been commonly used by a lot of the genetic testing labs these days. Now, speaking of AI and its ability to understand the language, I can say that for my 20 years of research, I've never seen something as powerful as ChatGPT, to be honest. And that is probably why it's no wonder that ChatGPT only took 5 days to grab 1 million users compared to much longer time for many other online popular tools and services. Now, previous speaker, keynote speaker, I already mentioned, just taking the out-of-box ChatGPT, you can see a very high performance, okay? Now, what I want to mention here is this is, again, the same results people showed earlier on the US Emory test. Things that we are sort of these days are so used to the great performance accuracy of ChatGPT. But I have to mention that for a lot of people like myself or in the medical AI community, we worked on this particular problem in the past for many years. And every time we try to do that prior to ChatGPT, 1%, 2% increase is considered groundbreaking and state of art. and very hard to reach like 40% or 35% previous years. So having that, getting close and, with the med prompt, it's over probably going to be in the 90s. It's just amazing. But a lot of these tests are actually operated by doing this evaluation on the multiple choice questions, right? So you're given a text and you want to answer the questions to pick in the right answer. And this is a significant limitation of this kind of evaluation because it's not real. In real world time, there's no ABCD choices. And also, even you picking the right answer, does that mean ChatGPT is actually reasoning with a sound rationale? So that was the motivation. We did this study earlier this year when ChatGPT 4V version was first launched, where we looked at to see whether by picking up the right answer, do they give us the right rationale? So there are two specific questions we're trying to address. How does ChatGPT 4V, which is the multimodal model, which can take both the text and the image together to answer a medical question, and that's the question we collected from the NEJM online testing. And then second question, more important question is, does this choice or this decision based on sound rationale? Okay, and we specifically look at three aspects. We asked ChatGPT not only to pick the right answer, but also to give us the reasoning in terms of how do you understand the image? What is the knowledge you use to answer the question, and what's your step-by-step reasoning? So we did this with over 200 questions. We recruited at the same time nine physicians and 1 MD students, and we looked at those questions across different disease specialties in medicine as well, different data modalities. Okay, now the first set of results is not surprising to some extent. Students about 60% and physicians at GPT-4V are equally about same, no statistically significant difference. And this is a physician without access to internet, without access to asking, consulting their colleagues. And in the paper, you'll find that if the physician can ask their colleagues or access to internet, they actually perform better than GPT-4V. But the second set of finding is actually more striking, is that even when GPT-4V answered the question correctly, about 30% of the time, it has some kind of errors or issues in either its image comprehension, which accounts to the most particular problem, followed by medical knowledge and the reasoning. And thanks to the previous speakers, I don't have to mention that there are other issues, right? So there are issues in the bias. One thing we did or published earlier is that we just take the medical records of a patient and we do nothing but rotate the race information of that patient from Asian to white to Black to Hispanic, and then ask for it to generate treatment guidelines, to generate diagnosis. And we don't even care about whether they are right or not. We only care, are they consistent? And we find they're not. Okay, and the other thing we did is we find that ChatGPT can really be easily tricked or manipulated. So with some kind of manipulation attacking strategy in its prompt or its training data, the performance can be very different. You can change a large language model that would normally recommendation like COVID-19 vaccine for everybody to something that would be nothing. Okay, and the even worse is that this type of manipulation will be very hidden to the users, because everything else, it just behaved very normally. But for that one particular task, it's completely changing the results. Okay. Now, having said that, I'm not negative actually about large language models. It's the opposite. I always say that I have two hands. One is to really explore the potential of large language, but on the other hand, because its power is so close to be ready to be deployed in real world time, it's now more important than ever before to thinking about those safety issues. So in the remaining few minutes, I'm going to give you very quickly two case studies. Okay, one is that, earlier there was a question, is this something that presented by our keynote speaker can be done by a academia lab? So speaking of an academia lab, I would think we cannot competing with Microsoft, those companies, given the resources we have. Okay, so my takeaway is we can improve a standard large language model using the domain data domain knowledge we have. And this is one great example where this is for basic research, which is a very common task to analyze a set of genes. And we were trying to find if you have multiple genes, what is the function together? Okay, now for individual genes, you can search NCBI gene database. But for the set of genes, the typical common used conventional method is gene enrichment analysis. Okay, so what we do, and people have done this before, is that you just given that set of genes to ChatGPT, and guess what? It actually gives the same similar performance to those conventional gene set enrichment analysis. But what we did here is adding this additional self-verification step, is that given that answer by ChatGPT or any other large language models, can we ask an AI agent to verify these results by adding using the domain knowledge, which has been invested and has been curated by domain experts in biomedicine, okay? So we're talking about just leveraging these databases that's already out there. Now, I'm pretty sure PubMed has already been used as part of training data by ChatGPT, but I don't think that these structured databases has been used. So if you can leverage this data, and as you can see that in the stats, in the bars below, that actually help improve the performance. So that's one example. And the other example, and then my last example is, and mentioned by many others that we can leverage, which is more clinical, is that we developed something using large language models for speeding up trial matching. This is a very real task for NIH PIs as well outside. And a lot of work has been developed, and including many of the people in the audience. But what we call it trial GPT, basically, we're looking at the patient node and clinical trial. But different is that we don't give this just a yes or no answer, because that's not what's actually going to be used in the real world time, because we need something that can be explained and use that as an assistant to the tool. So with that in mind, we have a paper coming out. You can look at the details, and given that I don't have time left, I'm just say that we did benchmarking to see that trial GPT actually works as good as human experts, as well as much better compared to the previous methods. So with that, even though I'm speaking, I'm really speaking on behalf of the people working in my lab, as well as our collaborators. I'm so glad that I see some of our collaborators here, like Dr. Sun here, working with us on the trial GPT. So with that, I'll be happy to take questions later on. Thank you very much.
Yes, thank you, Zhiyong, for the inspiring talk. So our next speaker is Professor Jie Liu from University of Michigan. And Jie is an associate professor of University of Michigan, and he's also a PI of the Planck base. So it's one of the newest large project of NIDDK. So without further ado, I'm going to invite Jie to give his talk.
Thank you so much for inviting me here. Especially arrange my talk after the PubMed talk. So first, let's talk about what is knowledge graph. So knowledge graph is a new database management system. It's different from traditional relational database. Everything is in a tabular. But here, the knowledge graph is just you have your data in represented at the node and edges, and on the node and edges, you can have further features on that. So at this, use this as an example. We have a variant, is an EQTL of a gene, and it's a GWAS associated with T1D. And this gene is expressed in the pancreatic tissue, and it also has an ontology term associated with this. So in this graph, we have nodes, and we have edges represent the knowledge, the relation, and also the properties on the edges or on the nodes. And also we can have nodes to present ontology. So probably you don't see a lot of knowledge graph in real life, but you are using it every day. Like in Google search, they use Wikipedia knowledge graph. When you search something, they will recommend something associated. And also, when you shop online on Amazon, they have product knowledge graph. When you shop, look at one product, they will recommend new product. It's all based on knowledge graphs. So I feel we can do something similar in biomedical research. Maybe you don't have the access to it, but it will help you to promote and get related concepts. So for this talk, I will mention 3 knowledge graphs I built and also built either in my lab or built with a larger team. The first one is called Genomic KB. We started in 2021. Initially, this knowledge graph is only for data integration. And later, in 2022, we add literature to Genomic KB. So we want to know whether we can further extract knowledge, like from PubMed, and then integrate into the data sets. And then this year, we have this exciting NIDDK supported Punk-based program. And we also have data literature and also resources like HPAP donors, library of analytics, models, many studies. So this kind of new layer on top of that, can we integrate resources on top of data and literature? And on the access perspective, initially for our Genomic KB, we only have web query, API, and we share the data dump with many research labs across the world. But then we are able to add LLM and then integrate machine learning, and we can see how that can enable many biomedical research. So first, let's talk about the Genomic KB. The first knowledge graph I built is only for integrating genomic data. The motivation is really back to 20 years ago when we complete the Human Genome Project. We profiled the human genome, we got the first reference genome, and then the epigenome project, we have the ENCODE roadmap where we profile the epigenome along the genome, and also the transcriptome, we profile the RNA-seq, the gene expression on every tissue and cell types. And then the 4DN, exciting the 4DN consortium that study how the genome is organized in 3D space in the nucleus. And there's also tons of large consortium analyzing and annotating enhancer activities. And as a result, that's the time when I started my lab. And I have many collaborators. They work on all type of data like this, genomic data. They have contact map, they have ChIP-seq, they have histomodification, they have enhancer, they have eQTLs, and they look at the data like this using a lot of genome browsers. So they want to see if this eQTL is located at the enhancer region, whether the enhancer form a chromatin loop with the TSS, and is there any histomodification, how's the methylation? So people has predominantly use genome browser for analysis like this. And you can imagine this is really helpful. The knowledge is aligned on the genome coordinates. And it's useful to see all the data together, but it's difficult to ask question, is there another region similar to this? How many regions are like this? How about a different cell type? Are they different? How much they are different? So because right now the data is only on the genome coordinate, it's difficult to address all these questions. So that's why we started this project 2021, and I have amazing trainee, Wang is also in the audience, who is the one who completed this work. So essentially, we collect all this data from over 30 data repositories, and then we carefully identify the element, the entities, the relations into an explicit graph. It's just one graph on the disk like this. So we have variant, disease, the traits, the genes, the signaling pathway, some of the peaks from epigenome, the ontology terms. So in total, we have over 300 million entities, 1.3 billion relationships, and almost 4 billion properties. We use a free version of Neo4j and put this kind of billions of things on the 300 gigabyte of disk. Right now we have over 2,000 active users across the whole world, and the data dump have been shared with over 30 research labs across the world for free. So this kind of way integrate this genomic KB, and once this knowledge integrated on the detail on the entity level, you have the variant linked to everything, you have gene linked to everything. We can ask queries like how many eQTL are there for the gene RFX6, and then you can just put this query in the system, and the system will automatically give you all the eQTLs under this condition. You can further add more conditions like one of the which of them are on in cancer region, which of them have the common loops with the ETSS. So everything can be done with a simple query because we have consolidated data on the entity level rather than on the genome coordinate level. So questions like this, it can easily give you an answer in this situation 135. And next is re-asked question, can we extract knowledge from literature? Just give you an example. It's a paper published, I think it's on bioarchive from Carl Gretton's group. And there's one sentence mentioning beta cell specific genes like insulin. And just using many tools, we can identify the entities, a relation, and then map them to the ontology and have these 5 nodes in the knowledge graph. And when we have new papers, they will map to the same vocabulary. So instead of isolated literatures. So this is how we build this, connecting PubMed with biomedical databases. So we have the ontology resolution module. So we select a large collection of ontologies and use ontology resolution. We merge them. That defines our controlled vocabulary. That allow us to identify all the data repositories. With this, we created the network on the bottom left of the curated network. That is essentially the data integration. And then on the right-hand side, we have the PubMed. We have every article is a node and use NER, RE, and EE, the event extraction. We can identify these entities and the relations, and using the same ontology, we will map the so-called the semantic network. In the end, the curated network, the data, and the semantic network, the literature get merged together because we have the uniform vocabulary. So that is kind of what we call the genomic literature knowledge graph, because this knowledge graph is still with a focus of genomics. This is kind of the summary, the statistics. So from this biomedical ontology, we focus on pathway, chemical disease, go-term gene autonomy, and organisms. We choose many of terms, and we identify the curated network, the semantic network, and in the end, we have the genomic literature knowledge base. It has 50 million nodes, 600 million relations, and then involve 100,000 terms, and it has a multiple level of embedding, including the abstract, sentences, and the terms. With this, we can ground LLM in question answering. For example, if you ask question, how are the gene RFX6 and PDX1 related to pancreas development? We have the planner that bring this question into 2 parts and then query our knowledge graph and identify literatures. And when they generate the LLM generate the answer, it always refer to the real references. I think this is really the powerful part. I think LLM can be so powerful and be more and more powerful, but they cannot give you the provenance. They cannot tell you where the source it comes from. But using our knowledge graph, explicitly linked to PubMed literature, we can provide this grounding information. So this is kind of how we answer this question. We use GraphRag. It's essentially query and retrieve the information from literature and then provide an answer with ground evidence. And we also test this how our GLKB help LLM in PubMed QA question answering task. So we also see the accuracy also improved a lot. Next, I would like to talk about the new Punker-based system. Is a really exciting program supported by NIDDK. So we will bring together data, pipelines, annotation, knowledge, literature, and collection of ontologies. We will build a future computation platform for people to share and perform the research. And there is a component of knowledge graph that is Punk graph. So essentially, we will use an explicit graph to connect all the resources in Punk base. So here we are just started February this year, and we are in the stage of designing an initial implementation. The goal is in January at the current annual meeting, we can do a soft launch. For the Punk graph part, right now we have a simple UI, hasn't been released yet. So we hope the LLM interface can support question answering. And with the answer, we can ground the LLM with the real literature by referring to the PubMed ID. And we will also integrating resources in the Punk-based system, like library of analytics, datasets, donors, and EQTL studies. And we also hope gradually we can build more and more AI into it, provide recommendations like generate hypotheses. So here is what's going on. It's really in the planning and implementation. We hadn't published this work yet. So this is really the situation when the questions became more open, like when we ask the question, what's the possible mechanism between gene RFX6 and type 2 diabetes? So with this knowledge graph, we can design reinforcement learners that can traverse the knowledge graph, and that will give you the passes along the knowledge graph. And then every path actually gives you a scientific fact that is from the PubMed literature. And with that, we hope we can design the reinforcement learner to smartly summarize and explore unknowns and give you the grounded hypothesis. So just to compare all these questions we can answer, we can, with the genomic KB, we don't only have the data, but not literature. We can ask simple questions like this. And then when we have the literature, we can use GraphRag that essential is retrieve and provide grounded answers. But then with this reinforcement learner and more advanced machine learning approaches, we can reason with the existing knowledge and propose new hypotheses, and it will always give you the ground information. Why they gave you this hypothesis? It's because there's literatures saying that. Just think about machine learning and LLM alone. When doing the training is data-driven and with less human supervision. Even human supervision is provided is usually after model is trained and then fine-tune the model. They train on diverse data set and different annotations, and they are not interpretable. We cannot trust them very well, and also the transparency is an issue. But when we supplement them with knowledge graph, we are looking at human curated and human controlled learning. We can use unified vocabulary and with resolved ontology. With this, we get the more interpretability, trustworthy, and transparency. I would like to acknowledge the support from NIH and internal grant from University of Michigan and our lab members and the Panther-based team. Thank you.
Thanks, Dr. Liu, for the very informative talk. And next we have another Dr. Liu, Hongfang Liu. She's a well-known professor of biomedical informatics at UT Health Houston. where she leads the research in the Center for Translational AI Excellence and Applications in Medicine. She was also a professor of biomedical informatics at Mayo Clinic, where she leads several projects on biomedical informatics as well. And she's a very well-known expert of NLP and works a lot on LLMs and other AI techniques for biomedicine and healthcare these days. So let's welcome Dr. Liu.
The slideshow, great. I mean, it's such a great gathering because the session, because the previous speakers touch upon a lot of things what I care about. But here I primarily will touch upon something from the systems level. And as I'm just go ahead. So in the past 12 years, I have been in the Mayo Clinic as a healthcare sectors and the system. They're a little bit different from academic universities. So if you're embedded inside of the health system, basically you've been asked to do a lot of things. And in the past 12 years, I have been working on many different hot topics in healthcare. Specifically due to the digital transformation, the EHR adoption, 2009, the ARA effort, meaningful use, we got a tremendous amount of data in the healthcare sectors. That kind of data usually is a powerful resource for us to do data-driven decision-making and data-driven discovery, all those different pieces. So, this slide basically summarizes some of the, healthcare sectors, how people see the data to be used. And in the center, you will see we have IT, which provide data infrastructure to support that. Security is a concern. Next is data science. It's basically implied that data, as we are doing data-driven decision-making, data science become essential. Lastly, if we want to deploy things to people, then informatics is a key component. It requires 3 different teams work together. And specifically, the concepts, this is 2005 to 2006-ish, we have this learning health system concepts. Basically say, since we digitalize all our healthcare data, then now that data can be a powerful resource for us to see and how to improve healthcare. Basically, if you have a health problem of interest, you can use the data to generate knowledge and the knowledge to performance, then dissemination, and just to keep that looping going. To me, actually, when I see this, they're learning evidence-based medicine basically use the scientific methods to organize, apply current data to improve healthcare decisions. And the best available science is combined with the healthcare professionals, clinical excellence, patient value to arrive the best medical decision for the patient. So if you look at this pyramid, basically the bottom relate to background information expert, and in the middle is consensus building, evidence seeking behavior. At the last is come to something which is perceived wisdom. So I need to go back. So want to show what's the difference between current healthcare AI and evidence-based medicine. In the past, we practice evidence-based medicine, which we leverage case reports and a guideline. So it's in the evidence-based medicine side, we see this as expert-based and human-centric. But in the right side, it's more like a data-centric, which is basically, we want to use our past data, all those real-world data connected, and come with things which we want to do as evidence for the future. Something I want to call attention. This is basically assume the past data is gold standard. In real-world data, we don't truly have gold standard. And I keep telling people, if you use EHR data to do any predictive modeling on this, you are assuming the data of the past is gold standard. We have gold standard care. That reality is not. But it does not prevent me to look at it, how we can use the data to the best to support. So over the past 12 years, basically the effort I was working on is primarily trying to make the data to be used. So we set up a unified data platform for learning health system. And this was part of the translation effort for one of the ONC project called SHARP-N, which is secondary use of EHR data. I was fortunate to be part of the team member there, and I was able to translate the results of the that grant to a enterprise data platform, and to really tell healthcare clinicians, researchers say the data can be used, actually a tremendous amount of work. And we do a lot of like implementation science related effort, including we are not only just do methodology advancement, we also need to tell people how to use the data. And we also need to train people across the sector system, say, we want you to be able to use the data also, and try to prevent us to be the bottleneck. And last year, we summarized the implementation into this paper in M.P.H. digital medicine is that we managed to have an in silico clinical phenotyping for learning health system. And this infrastructure was operated for 5 years and with, supporting about over 800 different learning health system projects. And meanwhile, also collaborating with clinician researchers and try to say you can use this data and use some natural language processing technologies so that the information from the unstructured EHR data can be leveraged for decision making. And this is a journey through a collaboration, which is how to translate NLP for real world application. Fortunately, this become an AI-powered application on the point of care. And also this being deployed as a smart on fire to enable clinical decision making. That's just one example. The second example related to real world evidence generation. This is reflecting, NLP technology can be leveraged and use real world data to generate evidence. Specifically, the target project is that silent brain function was not coded, and the clinical practice does not know how to deal with the preventive facts related to silent brain function. And how there's no clinical guideline, and the clinicians face problems, face the uncertainty related to what to do with those patients with incidental discovered silent brain function. And the objective for this effort is simply just say, okay, we can assemble a cohort using natural language processing technology through neuroimaging reports. After we discover those cohorts, then we can do a lot of evidence generation. Moving forward, this is basically through a very consensus-driven process, work with clinicians, working with researchers, and try to come up, how do we do that project? And it does have evidence generation component. This is just showing you that the cohort we identified as a silent brain function, if you have preventive metrics, depends on the modality of the data, you have different, risk, dementia-free probability and a stroke-free probability associated with if you have that problem or not. So we generate real-world evidence to say you do need to have a preventive care need to offer to those patients. So I think I will spend the last block talk about translation gap. We know these problems, model reproducibility is an issue. We touch upon this. And the primary reason is the process the process itself is not standardized. And the implementation of this is also not standardized. And the model portability issue, that's another significant problem faced when you try to deploy AI models into healthcare. And this fundamental go back to the issue we have. Everybody wants to do model work, not data work. As I said, healthcare data, our real world data is not a gold standard. In order to truly bring value, we do need to do data work. You need a data foundation, data infrastructure. You also need data curation, all those things around it. And this go back to the problem specifically, EHR systems. We have different implementation of Epic, even we unified from the probably EHR system from vendor choice, but the implementation has not been standardized. We have different data documentation, connection, extraction process. As an institution, we do have different IT data science infrastructure there, which cause a significant problem. And to show bring the evidence to people, actually, we did a scope review or literature review to show people there's a translation gap. Over the past, from 2009 to 2021, we see so much work we call measurement study, basically methodology development. We actually don't see much of those methods being used to generate evidence for real world evidence generation. So 2020, 2021, you only see, because of probably COVID, people busy with COVID, so we see very little. But it's most methods adopted is rule-based methods. And as an NLP researcher, we think that's the old generation, but also it's make us think why this happened. Why not use the state-of-the-art learning methods? Why use the things? So we have this portability, reproducibility issue. Can the generative AI deliver its promise in healthcare? This is the thing I want to show is that do we truly okay with the foundation models used to capture our existing knowledge in the space and a foundation model to capture our existing data in space through a hidden layer and get a model is okay to use? There are many contextual factors I already illustrated to consider as NLP development, and many contextual factors related to implementation. We did try to implement all the NLP approach algorithm we developed at the other institution with significant deployment implementation challenge due to they don't have experts or people there. There's a policy, you don't allow data to be out to set up a Docker infrastructure variation on the data. And I think this is from our keynote speaker, which is demonstrating maybe we should go to the generalist model. And then we have this issue as the hallucination, and people already touch upon, we can use knowledge base to help resolve that issue. And but at the same time, it's come also back to the data problem. How to prevent the cheese starting on pizza? This example, everybody probably heard it. And go back to the back of the data source. This was in the 11 years ago, somebody mentioned about it. So the data, the model itself is not perfect. And this is another example dealing with patient summarization using large language model. And no matter what we try, and 3 out of 10 times, the model will say the patient is taking Coumadin 8 milligram, but in the discharge medication was not there. We actually try to find out why. Probably because the real world data is a problem, because they should have that medication there. And lastly, just touch upon, Tina already mentioned, there's the bias, there's real world disparity associated. So I'm proposing this translational AI framework. I think let's not try to say, AI will replace a lot of work, and let's try to form as a team science approach, leveraging AI to address the real world problem, and leveraging translational science mindset, and leveraging a data science mindset to ensure AI bring the benefit. So this is the last slide. Basically, we hope for the healthcare of the tomorrow, we still practice evidence-based medicine, but that evidence-based medicine do have the data science component with the translation science in mind, and take a team science approach. That's it. Thank you.
Thank you very much. So we would like to invite all 4 speakers to the front. Okay, so I know we're running a little bit behind the schedule, but let's still have a short panel discussion. So we first want to give opportunity to the audience to ask a question to, any of the 4 speakers. Please use the microphone.
Hello. My question was for first speaker, Dr. Hernandez-Boussard, and I was wondering if you could give some thoughts on the FDA. And just to give my opinion real quick, I think the FDA is very asleep at the wheel. And I also don't think that just looking to the FDA to solve everything is the right solution, because how AI affects people is very context dependent. So I think every hospital needs to have a team looking at AI and how it's being used. So I'd love to hear your thoughts on where the FDA is at, and if any of the other speakers have something they want to say, that'd be good as well. Thank you.
There is a lot. A lot of talk about regulation for AI and the lack of standards and regulation. Of course, I don't speak for FDA, but I know they are trying to move forward with different types of regulations and standards for AI. The problem is that the FDA is used to regulating something that when you give it data, it always gives the same output. Right. And that's not the case with AI, right? We're continuously learning. So that's the challenge, because they can't, they don't know what the answer is going to be every time. But I think they are moving forward with things related to transparency, which I think is really important. And transparency meaning, using model cards and data sheets, et cetera, for models that are moving forward. But there's just a lack of standards, right? There's a lack of standards, and there's a lack of evaluations regarding fairness, regarding external validations. And so I think there's a lot more to do, but moving forward with transparency, I think, is a first step. And I know they're working on it. They are, it's hard because they're controlled by, other entities. And so their ability to regulate in this AI field is been a challenge. I don't know if anyone has any other thoughts, but definitely something that needs to be worked on.
Thank you.
Hi, this is my name is Sue. I'm from CDC's Office of Public Health Data Surveillance and Technology. This question's for the first speaker and the last speaker on the ethical concerns and just what AI means for healthcare of the tomorrow. I think I'm very from the CDC perspective, really, really concerned about what AI means for healthcare, but also what does AI mean for public health and community health moving forward. So given your presentations, would love to see you share a little bit more about your vision about where we can take it from a CDC perspective.
I think the data is there, in general, from the CDC point of view, the population surveillance. If the data not be, siloed, can flew, and those are having some signals you can detect. But on the other part is that the things concern me most is the data not there. Most of the low resource healthcare settings actually don't have data presence in this data surveillance component. And how do we ensure we take a implementation community engagement approach to increase that capacity, capability building would be critical. Otherwise, you only see one piece from those with resource. What happened to those settings does not have resource.
Yes, absolutely concerned about medically underserved communities.
Yeah.
Yeah, and I'll just add to that. I mean, look at what happened during COVID and like the N3C data set, right? So that was an enormous effort where we pulled together information from across settings, across populations, for specifically for COVID. But now that is, that is evolving. And now instead of focusing on COVID, it's now the national clinical cohort, I believe. And so I believe there are opportunities to really get that population level data. And then AI has been really good at, identifying, trends, noises, blips in the surveillance data, and being able to bring that in and really leverage that, I think is really important. But you have to have incentives for people to report their data. You have to have incentives for people to share their data. And so I think the CDC has a great opportunity to really provide those incentives across healthcare systems. But again, it's about what we were talking about, building that trust. So why would some of these populations, a community center, want to share their data with the CDC or other entities, and what do they get out of it? So it's really about showing them that this can help their communities, and that they're not being left behind. So it's like a catch-22, right? They have to share their data in order to have the benefits, but they don't want to share their data because they haven't had the benefits. But I think CDC has a great role here in making that happen.
Thank you all so much.
Thank you.
Hi, yeah, my name's Piper Bilo. I'm from Vanderbilt University Medical Center. And for full disclosure, I also served as the head moderator for our science on Reddit for 5 years. So I wanted to address a question building on the last speaker about equity and inclusion in AI models. I heard some of the speakers talking about utilizing Reddit as a platform, which is predominantly 14 to 25-year-old white males. I also heard other people from the panel talking about using EQTLs, which are most likely derived from GTEx, which is predominantly white participants. And I was wondering if we could address this issue and how you're thinking about trying to increase representation from other minority populations so that these AI models don't perpetuate health disparities.
I can go ahead and start. So it is a concern, right? But when we try and bring in the patient voice and the community voice, Reddit is something that's publicly available, so we can start bringing in those voices, and we can get insights for how that particular group is thinking about other populations. But I do agree, it is a big problem.
And want the voice of the chronically online edgelords. That's going to be the platform.
Yeah, but so we're also looking at other things like MedMD and all of these other online platforms. But when we talk about the populations that aren't connected, so we do a lot of work like in elder populations who aren't tech savvy. How do you get their voices? And that really goes back to our older types of research, our qualitative research, where we're interviewing patients and going to see them in their healthcare systems. And I don't think there's enough support and funding resources to really do that type of research, but it's so needed to understand how AI impacts these other populations.
Yeah, I would just really caution about mistaking Reddit sentiment for public sentiment.
Yeah, absolutely.
Yeah, I want to add a comment regarding that. Actually, our current evidence of clinical practice in reporting, we do have reporting issues regarding the underserved and the population. So in some of the things, we noticed that case reports, there are a lot of social determinant of health information was not there. and come to digital health tools being used for evidence generation, we also notice that a lot of reports does not report the table 1 with the necessary social determinants of information. So we do worry about it, and maybe come to publishers to ensure when you have table 1, make sure some other things also be described. So at least we are being transparent, informed with the current evidence. Are they not biased?
I'll just add a little bit. I agree with what our panelists said, but I also, and we know from our talks that AI and large language are very challenging regarding the equity. But I think this is also an opportunity for us because it's a capability that can reach out to the communities that were not necessarily are accessible for fair care. So just, for one, the reason that a lot of the real examples, a lot of the cases that refer to NIH clinical trials because they have primary care or they have special physicians, they know NIH is having this trial. But having AI tool that can actually open to everybody would actually open up opportunities for those people in those communities where they don't have this, that their physicians, they actually knowledgeable about these trials available nationwide. That's one example. Another example is AI actually can break the language barrier for many communities that actually previously were not able to get in the same knowledge or same information as others. So I think it's a challenge, but it's also an opportunity for us to do some things here.
Oh, I also like add 2 points. First, I think for knowledge graph or knowledge base, it's really easy to record where it comes from. We can have white study, African study. It's just one field on the edges or on the nose. And second, it's also easy to translate to different languages. I think this is really a simple task for knowledge graphs.
Thank you.
Thank you.
So the question from someone online, as a former clinician in both endocrinology and oncology, there's crossover. In cancer, the distortions that occur mean tumors can start producing hormones normally found in another cell type. AI will give the physician team more support, but she also is saying that crossover of oncology will be very difficult to get AI to sort that out. So maybe somebody can comment on that.
So I think our healthcare practice itself is the data is not really integrative care. So I was involved with one project with the FIAHSI QC, which is the federal quantified care settings, and they have a challenge to get, for example, oncology cancer treatment information to be in the primary care setting. But those people are seeking primary care in that, low resource setting with no data flow in. And so the primary care will struggle with care those for preventive care for those cancer survivors. So huge problem. It still go back to low resource setting, does not have the resource for digital capability. And it's a huge problem.
Thank you.
Hi, I'm Jim Kaput. I have a company called Vidiant. So we're at NIDDK. We're talking about diabetes, which is upwards of 80% lifestyle behavior. And yet we're not talking about any data for individual lifestyle data, the collection of quantitative data and the use in these models. So without that, I'm not convinced that precision medicine is ever going to work. But comments is what I'm asking.
Yeah, no, I totally agree. And that's something we try and look at is how do we capture this data outside of the healthcare system, right? Because lifestyle data is such a key component. And so one of the things we've been doing is we've been looking at the All of Us research cohort to try and capture some of that lifestyle data. I mean, they have over 100 surveys on lifestyle information, but we see the same problem is that people aren't filling out those surveys, right? The populations, the underrepresented populations aren't filling out those surveys. So I think that certainly in this room, we have the ability to think about what are the types of technologies we can develop to better capture this lifestyle information outside of the healthcare setting, right? Because healthcare setting is what, 5% of somebody's really disease. And so, I mean, I think it's a challenge for everyone in this room to think about how do we better capture that?
That's what we're working on. Yeah, thank
Polina Kukhreva, University of Utah. I have a question about the evaluation of AI models, which are already deployed in clinical practice. What can you say about using clinical trials, randomized clinical trials versus using real world data? For example, Epic Cosmos has half of US population in their database. Do you think the biases in real world data would not allow us to actually adequately evaluate AI models? And do we need to go back to clinical trials, or do we need to improve methodologies for using real world data for evaluation purposes?
I think my last slide was to touch upon that. We actually need a hybrid approach to obtain different kind of evidence at the different kind of settings. Clinical trials quite expensive, but we can leverage implementation science, pragmatic trial approach, and we also can leverage real world data. So those three ways of obtaining evidence to me is a future because data is there. It captures through labor, through clinicians. If we don't use it, to generate evidence to see hypothesis generation, all those different surveillance, all those capabilities. If we don't use those capabilities, we're missing opportunities.
So I'm maybe a little bit greedy, but I would say that any kind of evaluation we can do within the context is something that I would go for. Certainly, I would go for clinical trials, randomized trials, that if that's possible, but that's also very costly. But then if that, that's actually one of our projects, trying to see whether we can piggyback some of the existing clinical trials and then adding some of the AI tools to screen the patients for patient enrollment. But this is something we've been talking to our clinical collaborator for years. So we haven't get that point yet. We're still going to talking about that. But at the same time, we already have some retrospective real world data. So that's something that I would work on in the meantime. So that's sort of our approach. But all I want to say is that I'm not really a believer that multi-question answering is the best way to go, which is widely used and has been published a lot of the hypes that are because of that. When the other thing is a lot of these tests has been saturated, that does not really reflect the capability or the limitations of today's large language models.
Yeah, and I'll just add, I think that, you mentioned Cosmos, which I think is going to be something we're going to see being used more and more, which is the Epic database of EHR information. But I think there's two things. So back in, I believe it was the late 1990s, early 2000s, there was the Dartmouth Atlas, which really gave us information on provider variation and treatment variation. And there was so much insight taken from the Dartmouth Atlas. And now with Cosmos, we have this opportunity to really understand healthcare settings and variations at a population level, which we haven't been able to do before. But again, it goes back to, who has access to these different healthcare settings. Are the community healthcare centers included in Epic Cosmos, which I'm not sure, I don't know the percentage of that. But when you think about the 21st Century Cures Act, right, it's like, how do we better leverage this real world data? So I think it's a balance, right? We need to see more clinical trials to really test these hypotheses we're generating from real world evidence. And a combination of those two really will help us understand, so the causal relationships we're getting at.
Thank you.
So since we're running short of time, so maybe for the next 5 questions, let's try to keep it brief.
Yes. All right, no pressure there. Okay, so do you envision the IRB really becoming the ethical or the gatekeeper of the ethics? Because you mentioned that you wanted the more training in AI, and then also another speaker mentioned, well, when you are developing models, you should really include the implementation, workforce development that is required for that. and which seems to be beyond the scope of IRB and the scope of the research project itself. So how do you envision that happening?
At the transparency workshop that was an NIH funded project earlier this year, there was a lot of talk about the IRB and how it hasn't been updated in decades. And it really doesn't fit the type of research and the type of data we collect today. So I think there's big opportunities in advancing IRB to really think about the ethics of the research questions we're developing through IRB and having a component for ethics in the IRB. I don't think it's going to be a catch-all by any means. There has to be institutional incentives to really ensure that the research and the work being produced across universities, across different entities, really meets those ethics standards.
Ashley Xia from NIDDK. Yeah, I have a quick question in terms of sharing the models and the model interoperability. Because as mentioned by the speakers, there's lots of pre-assumptions built into the algorithm, right? Which is not transparent to user. And that there's a hidden bias in the data set that, hard to find. So when we share this model, what are your suggestions that how should we capture those critical things that will impact the actual usefulness of the model? That's one thing. And also interoperability. Different people develop so many wonderful models, how those models can be interoperable, and also what's the platform or some suggestion from system perspective to share those models and, make it publicly available.
I think that's a great question. I feel Hunger-Base is designed to do that. Think about we have the data shared, we call it data commons. We have the data, the library of analytics. We can build models on top of that. We can share the model. We can have the model trace back with data they were trained. And we will also have knowledge graph to record everything. I really feel that's really the platform can solve this.
Yeah, I think the privacy, model, there is a privacy risk in the model if you not generate, do careful data curation there. So it's fundamentally, I feel we all go back to the things, is that can we do share evidence from the model rather than model itself? Because fundamentally, I don't think if your model be trained using big data, real world data, where that data come from, you don't really know. So this is the ethical sourcing of data sets tend to be a big problem. We needed to really invest on that. How do we ensure things to be generated in a controlled settings to ensure, all those things be taken care of.
And I'll just add, there's a big push in the community to use model cards, data sheets, and nutrition labels to really help with model reuse and data set reuse. So I think we're going to see a lot more requirements and recommendations to use those types of tools for transparency and reuse.
It's Zhiyong Chen from Wei Cornell Medicine. So I have a follow-up question on the validation of the system. Previously, as the panelists mentioned about follow-up with a clinical trial, we all appreciate it's very expensive. But like what the third speaker, like Zhiyong mentioned about the PanBag database, a lot of basic science like models can be used to validate that. And also the last speaker mentioned your AI model predicts some prescriptions that which is not in the clinical doctor's prescription. Is there any current ongoing effort that to ask a clinician to evaluate whether they make sense or not before we go to very expensive clinical trial? Is there some intermediate validation step can be applied?
Yeah, well, at least for the type of research we do when collaborating with clinician, we always do that. We always, they would always sort of serve, let me take one step back. We would usually do the offline, normal precision recall F score type of thing first. But then once we see that kind of results, then the next thing is we would engage the physician because, their time is precious. They can't do as much as we would like them to do, but we would always ask them to actually manually look at the results and then give it on hints. So evaluation is a challenge. The best we can use is human physicians, but on the other hand, it's hard for that to scale. So there are proposals to using a second large language model to evaluate the first large language model, that type of thing. There's good and bad, as you can see, but we recently had one study where we trying to leverage the expertise from the physicians and using that to guide the second large language model to evaluate the AI output, and that seems to be a trade-off between them. Okay.
So the one thing is that experts, and if you have many experts try to build in consensus, it's actually quite challenging. So this go back to is that when we have human AI collaboration component is critical. Basically, as one expert, you try to evaluate the other expert, you have a lot of disagreement. The same thing can be true for, expert and AIs, except some obvious areas. So a lot of times, I think in the traditional evaluation data sets creation, they involve experts to generate gold standard, you will see their performance tends to be low. But if you involve layperson, performance high, but which one should we try? Should we trust? I think it's somewhere in the middle, right?
And I'll just add quickly that, what we're doing is we're asking 3 different models to evaluate the input, and then we're doing a diff between, Gemma, ChatGPT, and just kind of because manual annotation takes time. So we're trying to take a computational approach.
Oh, I also want to add a quick comment. I feel next generation physicians, they can do better and better leveraging these machine learning models. And it's also our task to advocate and educate. And also, I probably will teach my class use PancBase, right? And then I have many medical MD students took my machine learning class. I think this will be really carry on and on.
Yeah, we're really running out of time so maybe you can, keep the question very brief and then keep the answer one sentence answer.
Okay, sure thing. So my name is Jason Torres. I work with a company called Actionable Informatics. We principally support NIH. We're at all 27 institutes. And one of the things that I do is attend events like this just to get an understanding of what the priorities are, both for government agencies, academia, as well as industry. What are the best ways for us to engage folks such as yourselves or just the communities that you represent, just to share what we've learned from other events such as this?
One sentence. One sentence answer.
Teamwork is hard.
Okay.
There are meetings like this, both hosted within the NIH and outside in professional like AMIA meetings and others. So I would encourage you to attend those meetings and get a sense of what the most important topics that people are talking about.
And I would also say dissemination is really important. So there's so many meetings at NIH that we don't know, there's no way we can keep track of that. So having those come out in other forms of dissemination, such as publications, et cetera, I think is really helpful.
Perfect. Thank you.
I have a quick question from online. Someone in the chat is asking, is model organism data being used to complement the lack of data from diverse populations? And if so, how's that data being used? Model organism.
Model organism. Very quick.
Oh, sorry, I can repeat it really quick. But is model organism data being used to
Oh, yeah, absolutely. So when we think about the multimodal data, different data modalities, and as we heard from our keynote speaker, when we do that, we're definitely bringing in model organisms. So we're understanding how cell elasticity in mice can be learned and transported into our human models. We're doing work such as PSA shedding in mice and then understanding that shedding rate and bringing that back to our human trials. And so absolutely, I think there is a big component to really pull in all types of data, including from our model organisms.
And in one of the case studies I presented earlier, when we trying to use in different expert curated database to improve the standard large language model, we use model organism knowledge as well.
Thank you all. Thank you for the four speakers. So we're running out of time. So obviously this is only the starting point of the conversation, right? So please continue the discussion during the break and offline. And I think we're going to a very brief break, maybe 5 minutes, and then quickly come back because we're running behind the schedule. And then coming back, we're going to have the trainee flash talk session. Very quickly. Yeah, just 5 minutes. Okay. For all the flash talk trainees, please come to the podium. We can just set up slides. So,
You have a order for this class?
the first one.
Yeah, that's fine.
Hello, everyone. We'll started the flash talk section.
Hello.
Hey. Good morning. Getting close to the noon time, everyone. So right now, between us and the lunch will be our flash talk persons. This is kind of very intensive talk. We have the 10 excellent junior from trainees in here. Each one will get 90 seconds for the speech. I will going to introduce them, the name and title. It will be a race. So I count the time. Hopefully we can get everything done on time. So our first speaker is William Baskett. He is from the University of Missouri and a pre-doctoral trainee. His title is Adaptive Complexity Deep Learning Enabled Prediction of Out-Range Glucose Events in Adolescents and Young Adults with Type 1 Diabetes.
Great, thank you. So for adolescents and young adults with type 1 diabetes, controlling the glucose range of their blood sugar is important for long-term health benefits. Yeah, controlling the glucose range is important for their long-term health. Problem is actually predicting this with deep learning can be a little bit problematic because this is unstructured data. If you're using time series data, it's very easy to overfit if you overparameterize your model and train extensively. So we used data from the T1DXB clinical trial, which essentially included about 250 patients, provided time series data for their glucose, heart rate, meals, and insulin. And we leveraged a specialized deep learning architecture, which controls its own model complexity by self-simplifying itself down to an appropriate level of model complexity to avoid overfitting. Using this neural network architecture, we use the time series data from the data set, and we were able to predict the risk of out-of-range events within the next 2 hours and 4 hours with AUC of 0.77 and 0.82 respectively. So if that sounds interesting, come see my poster number 1. That's my time.
Okay, great. We have our next speakers, which is Noah Urologic. So he's from University of Pennsylvania. He's biomedical informatician. Abstract title is Modern Type 1 Diabetes Progression Using Machine Learning and Single-Cell Transgenomic Measurements.
Okay, hi. To detect the early molecular changes in type 1 diabetes, we devised a classifier to classify 3 groups of single-cell RNA-seq data, namely control or healthy donors, donors with type 1 diabetes, and then autoantibody positive donors, which are donors that are not positive for type 1 diabetes, but are positive for autoantibodies that are indicative of the progression or development of type 1 diabetes. We acquired from in-house acquired single-cell RNA-seq data from pancreatic lymph nodes, and after processing this through common single-cell RNA-seq pipelines, we aim to classify single cells using deep learning into one of these three groups, namely control, the autoantibody positive group, or the type 1 diabetes group. So in our early experiments with deep learning, we found that building binary classifiers for each of these, control versus autoantibody positive versus type 1 diabetes, etc., actually showed some okay performance when classifying control versus autoantibody positive cells just based on transcriptomic data from single cells. So the simplistic model showing some learning capability is promising while we go forward and try more complex models and refine the data to look at specific genes. Thank you.
Great. So our next speakers will be Hoifung. Okay, so maybe our next speakers will be, can switch that, Mohammad Ganjin. So she is from the University of Virginia. She's Ph.D. student in systems engineering. Abstract title is AI Augment Clinical Trials, Editing Continuous Glucose Monitor Metrics to Landmark DCCT Trial. Thank you.
I use this one? Yeah. Okay, so thanks for giving me this opportunity to present our work. So as many of you probably know, Diabetes Control and Complication Trial was a trial that was conducted in 1980s, and it established HbA1c as the main predictor of complication, long-term complication in type 1 diabetes. However, this data set is very sparse and limited, and it only has 7 SMBG profiles every 3 months and HbA1c every month. So it does not allow us to explore to see if any CGM-derived metrics can potentially predict the risk of complications. So what we've been interested in is to use AI to augment this clinical trial with CGM. So the question is, can we add CGM to this study and using AI and machine learning? And then if so, can we use CGM-derived metrics, or CGM-derived metrics have the capacity to predict the risk of complications? I would be happy to walk you through my poster and see you at poster 4. Thanks.
Okay, so our next slides will be Elizabeth Hiller, that she's from the Harvard Medical School, graduate student. Her abstract title is Leveraging Large Language Models to Analyze Continuous Glucose Monitor Data, a Case Study.
Hi, everyone. My name is Elizabeth, and I'm grateful to be here to share our work on leveraging large language models for the interpretation of CGM data. Diabetes management has dramatically transformed over the past few decades with the advent of wearable technology, including insulin pumps and CGMs. For patients with diabetes, daily management is an active process of synthesizing data to make medication adjustments and behavioral modifications for improved glucose control. While many patients are equipped to analyze the quantitative metrics and identify trends and plots, some patients may benefit from alternative ways of interacting with their data. For example, some patients find it extremely valuable to go to the clinic and have their provider walk them through their CGM data to help them interpret different trends and how they can make behavioral modifications. In our work, we're interested in how large language models can enhance the interpretation of CGM data for patients. Specifically, we designed a small case study to assess the ability of GPT-4 to analyze and interpret 14 days of CGM data for tasks that are conventionally done by clinicians when they're looking at an ambulatory glucose profile in the clinic. We demonstrate promising results in terms of the safety, accuracy, and suitability of these summaries, which paves the way for future work in this space and leveraging large language models to help patients understand their data and make actionable changes to their treatment plan. And I'd be happy to answer any questions at the poster session later. Thank you.
That's great. So our next speakers will be Miriam from the University of Virginia. She's trainee in Dell. Her abstract title is Multiple Horizon Blood Glucose Prediction in Type 1 Diabetes using Transformer Population Model.
Thank you for having me. And in our research, we focus on develop deep learning model for multi-horizon blood glucose prediction. And the one of the challenge in glucose prediction is inter and intra-variability in glucose level. So we combine CNN and transformer model to capture long and short-term dependencies together, and also we leverage population-based model to increase model generalization ability, and we evaluate our model on public data set and compare with other deep learning models that are most commonly used time series forecasting problems. And according to results, our proposed model outperformed than the others, and for especially short-term prediction horizon for 30 minutes and 4 hours. Thank you. Please visit poster 7 and for more information. Thank you.
So our next speakers will be Anisha Prasad from NIH Clinical Centers. She's a graduate student. The abstract is utility of pancreatic pancreavascular adipose as CT scan image biomarkers for diagnosing type 2 diabetes.
Hi, my name is Anissa, and I looked at using pancreatic paravascular adipose tissue, or PVAT, as a biomarker for type 2 diabetes. Pancreatic PVAT is fat surrounding blood vessels that supply the pancreas. So we wanted to quantify it on CT scans automatically and then use it to diagnose type 2 diabetes. So we trained a 3D NNU-net to be able to segment the pancreas and pancreatic vasculature, and then applied it to a second data set and isolated the paravascular region and filtered by the attenuation range for fat on CT to derive a pancreatic PVAT prediction. And then can we go to the next? Okay. So then we derived 4 biomarkers from the pancreatic PVAT prediction: volume, mean attenuation, standard deviation of attenuation, and fat fraction. And we found that all 4 PVAT derived biomarkers are significantly different in diabetic patients compared to non-diabetic patients. And then when we combine these biomarkers with other known biomarkers for type 2 diabetes, we were able to get a maximum AUC of 0.90 for diagnosing type 2 diabetes, which tells us that PVAT-derived biomarkers can be useful in diagnosing type 2 diabetes. And for more information, come to poster number 13. Thank you.
Thank you. Our next speaker will be Eloyd Parra. He's from the University of Virginia, Ph.D. student in Dell, neural network minimized MPC implementation.
Thank you. So in general, with precision medicine, we're trying to develop complicated models to optimize treatment therapy. And this leads to strategies like model predictive control, and these can be computationally intensive. At the same time, we're making these more computationally expensive algorithms. We're trying to miniaturize everything. We're trying to have miniature neural networks, or we're trying to use miniature insulin pumps. We have wearables like smartwatches, and these are kind of in direct opposition of each other. So how do we practically deploy these complex algorithms on an embedded system? And we use neural networks. So we copy the complicated algorithm using a neural network, which is just some simple linear algebra. We've done it in the past, but one of the problems is it has a large memory footprint. So we shrink the memory footprint and we show some trade-off with accuracy in representation and also clinical metrics via simulation on how well do we balance trade-offs in accuracy versus performance. And this allows us to embed complicated dosing algorithms in the embedded system to improve like battery life and yeah, practically use this. Cool.
Thank you. So our next speakers will be Miranda Razahara from the University of Arkansas. She is early stage investigator. So her title is Pediatric Asthma Population Segmentation through K-means Clustering.
Well, I'm excited to be here. A little break from diabetes. So my presentation is about another chronic conditions among children, asthma, and it really showcases how we can use machine learning algorithms to identify subgroups of children who have higher risk for asthma-related exacerbations, including ED visits and hospitalization. So a lot of traditional measurements that healthcare systems and insurance companies use still rely on NCQA's HEDIS measures that are mostly based on healthcare utilizations, and they do not take into account social determinants of health. So in this study, we use social determinants of health, and we linked the zip code of children to the social determinants of health defined by Child Opportunity Index. And in addition to social determinants of health, we included comorbidities and their asthma management level, including the controller and reliever medications that they used from the data in all-payer claims database that includes longitudinal data on not just the healthcare utilization, but also allows you to look at the enrollment data to get to their zip codes and try to link zip codes with some of the great available social determinants of health. And what we found that when we characterized the clusters, so we used cluster analysis and to yield distinct clusters and then characterize these clusters based on the traditional measures, which is the HEDIS measures. And we found that some of these clusters, there were some children that were not picked by these traditional measures, but they still had higher rates of exacerbations, ED visits. And then we further looked at their socioeconomic status across three different broad categories of Child Opportunity Index. We found clusters that children residing in neighborhoods with very low opportunities across these social economic status, like economic and health and environment factors within the neighborhood. So the policy implication of this work is that insurance companies, healthcare systems should start integrating these social determinants of health. And we need to integrate these measurements, as one of the panelists mentioned, into our data science approaches and to identify children with higher risk for adverse outcomes. Thank you. My poster number is number 15.
So our next speaker is Valentina Redmond. So she's from Oregon Health Science University, graduate student at DEM. Her abstract is a look inside machine learning black box models. What can we learn from predicting probability nocturnal low glucose in type 1 diabetes?
Okay. Nocturnal low glucose is a challenge for people living with type 1 diabetes, especially for those who are physically active or on multiple daily injections. To address this problem, we developed an evidential neural network to predict the probability of nocturnal low glucose, using as inputs glucose data, demographics, and physical activity data. This algorithm was used to design a smart snack intervention to avoid nocturnal low glucose, and its effectiveness was tested in a crossover clinical study. We used the data from this study and a technique called Shapley additive explanations, CHAP, to investigate the key variables associated with the predicted risk of nocturnal low glucose. The results are presented in the figure. We found that the most relevant feature was glucose at bedtime, for which we found that lower values of glucose at bedtime increase the risk of nocturnal low glucose. These insights may be used by clinical decision support systems to help to educate people living with type 1 diabetes, to help them to recognize higher risk events and behaviors to avoid nocturnal low glucose. Thank you, and further information in the poster number 16.
So our next speaker is Ioannis Teratos So from University of Southern California, Trainee and Dale, abstract title is leveraging statistical and machine learning models to identify key lifestyle predictions of type 2 diabetes risk in youth.
Hello, hi. The incidence of type 2 diabetes in children and teenagers has nearly doubled in the past 15 years. Children with type 2 diabetes, contrasting with their adult counterparts, are more likely to develop serious diabetes complications such as blindness, end-stage renal disease, or heart attacks because of their duration of diabetes. According to the search study, nearly 3 out of 4 teenagers with type 2 diabetes already have at least one of these serious diabetes complications. What makes these stats truly devastating is that these young people are living with these complications that are life-threatening and debilitating during what should be the most productive period of their lives. Youth onset type 2 diabetes is actually less reactive to standard treatments such as metformin or lifestyle changes. All of this can be backed up by the search study, the Today trial, and the RISE consortium. The question that we would like to ask is, can we identify lifestyle factors that predict risk for T2D in children? And our approach is using machine learning techniques. We can discover the relationships between lifestyle factors and the risk of developing hyperinsulinemia, which is a precursor to the development of T2D. Using these predictive insights, we can empower families and healthcare professionals in their in type 2 diabetes risk in their children. Thank you so much.
Okay. So our next speakers will be Hongfang. So she is a postdoc researcher. Let me open her slides. So he's from Vanderbilt University Medical Center. He's postdoc in Dell, and his abstract is defining human islet cell compositions and spatial distribution across different diabetes forms.
Okay, thank you. So multiplex imaging techniques, including codecs, allow us to visualize tens of protein markers simultaneously in the same tissue section. In the past years, we have So we visualize tens of protein markers simultaneously within the same tissue section. In the past years, we have profiled codecs for pancreatic tissues from the Human Pancreas Analysis Program to closely study the cell composition and cell distribution in human pancreas. And luckily for the same set of donors, we have detailed donor demographics and other modalities such as single-cell transcriptomics, making it an exceptional database for cross-modality analysis and multimodal AI. However, just for those images, we still don't have a robust and standardized pipeline to annotate cell types and investigate cell spatial composition of cells. Therefore, we developed a computational pipeline to analyze those images. It includes 3 major steps. First, we use high precision image segmentation to identify cells. Then we have an accurate cell type annotation pipeline called fingerprint matching. And in the end, we also analyze the cell neighborhood from the images. This pipeline could capture the spatial composition of human pancreatic cells. So currently we are applying this to across our data set, focusing on pancreas and islets in different disease stages. By doing so, we are trying to understand the role of cell composition and cell-cell interaction in the disease progression of diabetes. Thank you.
Okay, our final speakers is Yang. So let me open his talk. So Yang is a young investigator. He also educated 5 trainees. He's from Emory University. So his abstract is EHR agent. Code empowers large language models for few short complex tubular reasoning on electronic health records.
Okay, so sorry for being the blocker. This is the last talk, and it's not very specific about diabetes, and not saying I'm not doing diabetes research. Just trying to bring some of the recent progress using the fancy language models. So I'll just go ahead. The EHR agent we developed is basically a coding agent that uses language models to write code. And this code is about retrieval data and do some computations from the retrieved data. So the questions usually asked by clinicians could be as simple as what was the the length of the last ICU stay, or as can become more complicated as for example, what would be the maximum total hospital costs of a certain patient diagnosed with a more complicated disease and in a certain range of years, right? So you can imagine this query could be mapped into a pretty complicated SQL or some code, right? If you are going to write that code and search the database and do the calculation yourself. So this agent basically tries to do this for the clinician. So the clinician can form the question any way they want, like in natural language, and then the language model agent will try to write that code and do the work. Right. I probably don't want to go into too much detail about how technically we do that, but the idea is we make use of the metadata of describing the database, like a particular EHR database, right? And you don't need to really write this metadata yourself, right? The language model can also process the metadata, basically to extract the table names, the column names, the relations between the columns, and put this in a prompt. And then we will also use 5 general examples about what kind of questions could be and what is the corresponding code, right? We are using Python to write the code for these tasks. And then there is I don't know what it means. I assume I haven't started yet. So I pretend I haven't started yet. And there are some other functionalities, like we use the agent to do coding itself, right? And also check the error message, interact with the executor, the code executor, right? Check the error message, try to see how the error was generated, right? And then improve the code. So this is mostly the technique. And we did the experiments. Finally, we saw the experimental results, which showed our agent to be pretty excellent. And yeah, more details, please check poster 20.
Okay, please remember the poster 20 for Karya in here. And excellent speakers for here, and I welcome all the fresh talks. So right now we'll have the lunch break, and after that we will have the 12:50 to come back for our section 2. So hopefully we have our lunch is in the beside in here. You have label name in there. You can pick up the lunch and come back during the 12:50. Thank you.
Okay, so welcome everyone. Welcome to session 2 that is going to be focused on AI-based precision medicine in diabetes and other chronic conditions. It is my great honor and privilege to welcome speakers for this session, outstanding speakers. I would like to also introduce my co-moderator, Dr. Mandana Rezahari, who is in Department of Public Health at the University of Arkansas School for Medicine. We are gonna have Dr. Polina Kukareva over there. She is assistant professor in biomedical informatics at University of Utah. She will be taking our questions during panel discussion from online participants. And I just thought that we had really great morning sessions just to reflect on where we are and how we go forward with AI in precision medicine for diabetes. I was thinking today in October 2024, all forms of diabetes are still diagnosed by measurement of blood glucose, right? Pancreatic beta cells that I'm very passionate about as an islet biologist we don't have therapies protecting beta cells, right? And we do not understand molecular and genetic features of diabetes and diabetes heterogeneity to build toward precision medicine for diabetes. So can AI help us bridge the gap between basic and clinical and translational research? And I think we're gonna hear in this session from clinicians and also those who are interested in bringing in large data sets from real world, right? And we heard earlier this morning about new initiative within NIDDK called Pancreas Knowledge Base that is primarily focused on basic science. So can AI help us connect basic science discoveries to clinical and translational research to come up with new biomarkers for diabetes, new therapies, and really pave the way for diabetes prevention, which is aspirational goal, but I hope we will get there, right? And with that, I would like to introduce first speaker in this session, Dr. Miriam Adler. She's assistant professor at Harvard Medical School. She's associate member of Broad Institute. She's an endocrinologist, and her lab is studying genetic contribution to metabolic diseases and clinical application of large genomic data. And with that, please come up to the stage. We're gonna go.
Great. Thank you so much for the introduction. Thanks to the organizers. This is really a fantastic workshop, and I'm excited to tell you about our research, but really excited to learn from all of you throughout this meeting. Great. So our work has been focused around trying to leverage this massive discovery that's occurred over many years now for genetics of type 2 diabetes, and try to use all this genetic discovery to help us better understand the pathophysiology of type 2 diabetes. So as you can see, let's see if you can see. Sorry, okay. Great. So you can see this is a figure showing over many years the progress and discovery. We now have over 600 genetic loci associated with type 2 diabetes. And we'd love to be able to take all this discovery and help us inform on disease mechanisms. However, as many in this audience know well, this is incredibly challenging to move from loci to disease mechanisms. And this is because typically at a given locus, the causal variants in genes are unknown. And then all the steps that require to go from a locus to mechanism, so fine scale mapping, functional genomics, experimental follow-up, they're very labor and resource intensive and very difficult to scale. So we wondered whether there might be ways of taking kind of a shortcut from the standard approach of going from variant to function and seeing if we can more directly connect variants to physiological function by looking at the associations that genetic variants have these are genetic variants associated with type 2 diabetes, but how they're associated with other clinical traits. So this type of work requires having a set of type 2 diabetes genetic variants that represent these loci, and looking at the allele that increases diabetes risk and seeing how it affects various other diabetes-related traits. And this is really a data-driven approach where we can use machine learning in the form of cluster analyses to group these variants together so that we get sets of variants that share a very similar pattern of associations with various traits. And then by looking at that pattern of traits and by looking at some of the loci where we know more about the functional implications, we can start to map these to mechanisms. So this work actually started quite a while ago, about 10 years ago. One of the earliest efforts to perform this type of genetic clustering was through a consortium called MAGIC that studies glycemic traits. And at that time, there were 37 loci, and they looked at 47 traits and performed unsupervised hierarchical clustering. And they identified, which was really groundbreaking at the time, sets of variants that related to beta cell function and insulin resistance. And there was some really nice groupings, but there were challenges with this type of approach that it can be challenging to define how you group the clusters. And then when you use a hard clustering approach, there's an assumption that any given locus belongs to just one cluster, which may or may not be consistent with complex disease biology, where we may assume that a given locus could be affecting multiple genes, multiple pathways. So when we started,
sorry, slides aren't advancing on Zoom.
Okay, great. So when we started thinking about this problem, let's see, or maybe I'm looking at. Let's see. Okay, great. So we were looking for a more flexible framework that could allow what's called soft clustering variants to be part of more than one cluster. And we're fortunate that at the Broad Institute, there were colleagues working in the cancer genomic space, but had been developing an approach called Bayesian non-negative matrix factorization, and they were applying it to cancer genetics, but were willing to collaborate with us and try to adapt their approach to our diabetes question. And so we, at that time, we had 94 variants and 47 traits that we could perform cluster analysis on with the soft clustering approach, where in here variants can have weights in more than one cluster. We identified 5 clusters. And what was also very appealing and in some ways remarkable at the time was that these 5 clusters were really readily interpretable. 5 clearly related to mechanisms of insulin deficiency, and 3 related to mechanisms of insulin resistance. Around the same time, there was an independent effort that also looked at a distinct but overlapping set of SNPs and traits, used a different clustering approach and identified the same 5 clusters. And I'll tell you about throughout multiple different efforts now with different data sets and different clustering approach, these 5 clusters continue to be quite robust. So in 2023, we expanded our approach to a high throughput pipeline so we could keep up with the growing number of diabetes genetic loci being discovered and GWAS for traits. So we looked at over 300 variants, 64 traits, identified 10 clusters, but again, we identified these 5 as well as novel clusters. And this high throughput approach could let us pull from genome-wide association studies, summary statistics, and we've now been able to apply this to many other conditions, and other folks are applying it as well to other conditions. So that, and one thing that's actually really interesting is seeing when you start with another disease where you see overlap though with clusters or mechanisms that relate to diabetes. So most recently in the last year, there's been 2 efforts, one led by our team and another led by the Type 2 Diabetes Global Genomics Initiative to expand these approaches to a more multi-ancestry framework. So our analysis looked at 650 variants, 110 traits, identified 12 clusters using the BNMF approach, and the T2D Global Genomics Initiative performed the largest multi-ancestry GWAS at the time, and so included over 1,200 SNPs, 37 traits, and performed the unsupervised hard clustering approach and identified 8 clusters. But again, all these approaches still were able to identify these same 5 clusters in common. So just to give kind of a visual of how the most recent efforts relate to each other. So the TGGI work is this, the hard clustering Suzuki et al. Nature paper. These are showing 5 of the clusters from that work. And then our Smith-Deutsch Nature Medicine paper, we see that there's nice concordance that actually we validated genetically that we have sets of genetic loci that are in common between the clusters that we've listed next to each other. And with the soft clustering approach, by including more traits, we've been able to break some of these clusters into subclusters. So for example, the cluster related to insulin deficiency that with an increase in proinsulin that we've termed beta cell cluster divides into beta cell 1 and 2 in our most recent work. And then both approaches, and actually multiple of the papers I've mentioned, have also been able to connect these genetic clusters to tissues and cell types using epigenomic data. So to show you this, the epigenomic analyses, so in our early work, with the 5 clusters, we saw, for example, a very strong enrichment of the beta cell cluster with pancreatic islet bulk tissue. And in our more recent work, we again recapitulate that the beta cell 1 and beta cell 2 being enriched in pancreatic islets, but we also, with the ability to look at single cell data, looking at alpha, beta, delta, and gamma cells, start to see that the sets of the subset of these clusters, beta cell 1 and 2, map to specific cell types within the pancreas. And I'll mention that this is work in collaboration with Kyle Galton, and Kyle will be speaking tomorrow. So how can we start to apply this to patients and people? Well, we can take these sets of genetic clusters and generate what are called partition polygenic scores or process-specific polygenic scores, essentially taking the sets of variants in each of the clusters and generating a polygenic score that represents a person's genetic risk for the specific disease mechanism. So in just the remaining time, I'm going to just briefly take you through how these process-specific polygenic scores can inform on disease mechanisms. So first, we see that these scores help recognize convergence of polygenic and monogenic disease mechanisms. So one example of this is monogenic lipodystrophy that's caused by rare variants that cause a very distinct clinical phenotype of increased type 2 diabetes risk, insulin resistance without obesity, increased triglycerides, decreased HDL cholesterol, and a fat distribution favoring the viscera versus the subcutaneous space. So what we see is that there's clusters that we've termed lipodystrophy-like, because what we've seen is that people that as you increase their polygenic score for these clusters have a very similar clinical profile. And what's important though is that we're still not at the point where we can find an individual person that has a very high process-specific polygenic risk and say, okay, you have this genetic subtype of diabetes. It's more that we can see in an aggregate groups of people that have a high risk have a particular clinical feature. So this is still, so it's helpful for dissecting clinical heterogeneity, but not yet at an individual level. And just taking that just a step further, essentially each of these genetic clusters, so we have 12 in our most recent work, define a distinct clinical profile. And we've shown this with individual level data from the All of Us study in the Mass General Brigham Biobank. I won't go into detail just for the sake of time. So another aspect of how these process-specific polygenic scores can be translated is in terms of defining cellular phenotypes. So Melina Cloud-Sister's lab at Mass General and the Broad Institute took fat biopsies from individuals and generated adipose tissue-derived mesenchymal stem cells, and then looked at these the lipocytes at various time points in development and perform this profiling that could identify different features of the cell, such as the lipid droplets, or mitochondrial activity. And with this high throughput approach, could be able to look at the features at scale. And so then they could ask the question, do people at high versus low polygenic risk have different cellular features? And they looked at both the subcutaneous adipocytes and the visceral adipocytes, and with the full type 2 diabetes polygenic score, so including all alleles associated with type 2 diabetes, there was really no difference in people that had a high risk versus a low risk. However, when they looked at the polygenic score that was more specific for this lipodystrophy mechanism that I mentioned earlier, there was this real explosion of signals specifically in the subcutaneous adipocytes. And in fact, on ground truth imaging, there was a really clear cellular profile where people that were high risk had smaller lipid droplets. They had this increased red mitochondrial activity. And this actually fits with the same cellular profile that's seen in monogenic lipodystrophy, where we're seeing this shunting of fat from the subcutaneous tissue towards the more metabolically dangerous visceral tissue. So then finally, we were interested in whether these process-specific polygenic scores could contribute to global clinical heterogeneity that we all recognize exists in people with diabetes. So we know that depending on where a person's genetic ancestry is, that their BMI threshold for developing diabetes differs. So in particular, what I'm showing you here in blue is East Asian genetic ancestral subgroup compared to European genetic ancestral subgroup. And so the group that's East Asian has the same risk of developing diabetes as the European subgroup, but at a much lower body mass index. And this is very well appreciated, something that we even take into account clinically when we are counseling patients on goal BMI targets. So we were interested in whether the process-specific scores might be contributing to this, and in particular, the lipodystrophy polygenic scores, given that there's been some data suggesting that in East Asian populations, there's a propensity towards, as there's increased fat, that it tends to accumulate more in the visceral space. So we saw indeed that adjusting for these lipodystrophy polygenic scores could account for the majority of this difference in BMI thresholds. And indeed, these particular alleles are more common in the East Asian ancestral subpopulation compared to the European subpopulation. So just to summarize, so our approach has really been about trying to take the genetics of diabetes to elucidate disease mechanisms to improve our understanding of disease pathogenesis. We've been able to identify multiple disease processes now, some that are shared with monogenic disease. We can connect these processes to tissues and cells. We can dissect patient clinical heterogeneity, still in aggregate, not at the individual level, define human cellular phenotypes, and inform on some of the clinical differences that we see across global populations. So there's a lot of work we're continuing to do, and all really requires AI methods. So I think this is something that will be really wonderful throughout this meeting to discuss how we can continue to improve. So we have been already starting to enhance our clustering pipeline, working with the TGGI collaborators. We are layering omic readouts to uncover disease mechanisms to really understand better what these genetic clusters truly are pointing at, and then ultimately connecting these mechanisms to treatment. So I will stop there and thank the many people involved in this work, many our team members and collaborators, and happy to answer any questions during the panel and throughout the meeting. Thank you so much.
Thank you, Dr. Adler, for your insightful talk. Our next speaker is Dr. Hemang-Parikh. We are pleased to have Dr. Hemang-Parikh with us today. Dr. Parikh is an associate professor at the Health Informatics Institute, University of South Florida. Dr. Parikh contributes to multiple international collaborative efforts, including the Environmental Determinants of Diabetes in the Young, Type 1 Diabetes TrialNet, and the Rare and Atypical Diabetes Network Gradient Study. Please join me in welcoming Dr. Parikh.
Thanks for the introduction. It's my great pleasure to be here. It's my honor to present a Radiant study, which stands for, let's see. Okay. Stands for Rare and Atypical Form of Diabetes Network. And this study is funded by the NIDDK. Thank you. So the main objective of the Radiant study is to identify patient and family with a novel and rare form of the atypical diabetes and characterize their molecular mechanisms. And we are performing lots of genetic and phenotypic characteristics of these patients to understand their clinical applications. And also from NIDDK point of view, we are constructing a huge biorespiratory and database. And this data can be shared between scientific community through Radiant ancillary study protocol. So as you know, if you define the distribution of different types of diabetes, 91% of diabetes patients are usually type 2 diabetes, 5 to 6% are type 1 diabetes. And Radiant study is designed to find rare disease. So what we are looking at the other forms of diabetes, not including medical induced diabetes, for example, glucocorticoid base or disease or dysfunction of exopancreas, or looking at the monogenic type of diabetes. So main aim of the Radiant study is to define certain criteria to identify rare form of the diabetes. And for that, the consortium came up with this inclusion criteria as well as exclusion criteria. So inclusion criteria includes the type 2 diabetes patient. We are very young age to define. They are non-obese. There is clear Mendelian pattern and early onset in these children or in teenagers. And they progress very rapidly or very slow progress. They don't require that much insulin, as well as looking at changing glucose levels over time. And we are also interested very much is A-, B- classification. Here, A stands for autoantibody negative or autoantibody positive or negative, and B stands for beta cell function. And this group consider mostly ketone-prone diabetes patients. And we are not interested in this particular radiant studies to remove typical type 1 diabetes, type 2 diabetes, and also known form of monogenic diabetes. And we didn't include any pregnant women for the clinical application point of view. And we are doing genetic testing. So anyone who refused to be participant in genetic testing, we put as an exclusion criteria. And this is a huge large-scale consortium. We have 14 different clinical sites from all over place in the United States. And University of South Florida, where I'm from, we represent Data Coordinate Center. And we have central lab at University of Florida doing autoantibody testing and so forth. We have central RB at University of Utah. And we have core labs, including Broad and Baylor College of Medicine. And this is the web page for the Radiant. And then all the data, whatever is available, all the questionnaire data is available in English and Spanish. So how we designed the Radiant study is basically in 3 different stages or 3 different parts. And all ages and ethnicities are included in the Atypical Diabetes Consortium. And also we ask family members to be involved. So in stage 1, the person can participate in an online questionnaire. And based on that questionnaire answers, we collect the blood sample for autoantibody testing. And based on the results, adjudication committee of the Radiant, they move these subjects or these participants to be part of the stage 2 or not. And in stage 2, we perform genome sequencing, and that's the result goes to discovery team. And what they decide is that if there has a known form of monogenic disease, they are not included in stage 3. But most others are included in stage 3. And for these participants, we collect lots of deeper phenotypic data as well as lots of other clinical data. So far, the Radiant started in about close to 4 years ago, and we recruited, or at least stage 1 question were finished by more than 1,800 participants. And out of that, 994 participants were actually being adjudicated. It means we are clinicals look at their data, and they identify 55% of the participants to be eligible for stage 2. And then we have collected the whole genome sequencing data for these participants. And we currently have 382 participants in stage 3, in which we collect deeper phenotypic data, including OGTT or glucose tolerance and several other laboratory testing. So in Radiant, we collect lots of clinical data, including medical history, clinical evolution, as well as metabolic testing, RNA sequencing, mitochondrial sequencing, and metabolomics data. So we have a large scale of omics as well as clinical data. So looking at the spectrum of within an atypical form of diabetes, this is the different cluster or subgroups we identify based on clinical classification. And largest group was mostly non-obese insulin insufficient diabetes. We have quite a lot, most likely monogenic or oligogenic form of diabetes. And we have a quite KPD form and also insulin deficient diabetes having autoantibody negativity. This is just to show you the amount of questions data we have and amount of variables we get from this Radiant data. So just in stage 1, we get up to 2,500 variables. And these are the different sections each participant fill out. And we get a huge amount of questionnaire data. And over time, in different stages, we have close to 10,000 variables. So it becomes quite challenging to analyze this data. So this is an excellent consortium to learn and apply different techniques for the Radiant data. In this particular analysis, what we have done is to define unsupervised clustering, looking at the clinical data and see how we aligned with the known form of subtypes of the Radiant. And here we use the stage 3 data and identify 4 different subgroups of the atypical diabetes. And just to overlay what is being known before is that cluster 1 mostly represent non-obese insulin insufficient diabetes. Cluster 2 are mostly showing monogenic or oligogenic diabetes. And cluster 3 showing antibody negative insulin insufficient diabetes and so forth. And cluster 4 was looking at the mostly ketone prone diabetes subjects. And just give you overall of the radar plot, just showing these two subtypes of the radiant or atypical form of diabetes. What we have found that the non-obese insulin insufficient diabetes has a little bit older as compared to antibody negative insulin deficients. And they have DPT-1 score, which is basically type 1 diabetes risk score of prediction model, has also been a little bit higher in the antibody negative participants. I'm happy to quick any question up during the panel section. Thank you.
Thank you very much, Dr. Parikh. Our next speaker in this session is Dr. Ronald Ma. It is my great honor to welcome him at this workshop. He comes to us from Chinese University of Hong Kong, where he is a head of Division of Endocrinology. He's Associate Dean in the Faculty of Medicine there. His long-term interest has been epidemiology of diabetes and also focusing on diabetes of the young and gestational diabetes. He leads Biobank, Hong Kong Biobank, and he's a recipient of award from Asian Study of Diabetes for his accomplishments in epidemiology of diabetes, and has been very, very active in the area of precision medicine in diabetes, collaborating with American Diabetes Association and also European Association for the Study of Diabetes. So please.
Thank you very much, Marcella, for the kind introduction and the opportunity to join you all. So I'm an endocrinologist with an interest in genomics, and it's great to have this opportunity to learn from everyone about application of AI. So I've been asked to give a perspective from Asia regarding sort of thinking broadly about precision medicine in diabetes. So what I'll try to do is to talk a little bit about diabetes sort of from an Asian perspective, and then talk a little bit about some of the initiatives that we're trying to do to understand the heterogeneity of diabetes within an Asian population, and to talk a little bit about how we're thinking in terms of implementation. So Asia is one of the several epicenters of this global pandemic of diabetes. And unfortunately, you can see from this data that in many regions in Asia now, around 1 in 5 individuals have diabetes. So in Korea and also in Malaysia is about 1 in 6 of the population. And it continues to increase. We have a large proportion of young onset diabetes that I'll talk about. So Hong Kong has transformed rapidly over around 100 years from this small fishing village to this very cosmopolitan city. And the price we pay is that we have prevalence of diabetes well over 10%. The great proportion are type 2 diabetes, individuals with type 2 diabetes, but we also have a significant proportion of young onset diabetes where about 1 in 5 of our patients are actually diagnosed before the age of 40. And of course, compared with individuals without diabetes at that age group, they're marked increased risk of cardiovascular disease, and in particular, a high burden of nephropathy in our population. So our group's been interested to try to understand the epidemiology and pathogenesis of diabetes in Asian population. And over the years, we've built several database cohorts to try to understand the development of diabetes in Asian population, and also to identify biomarkers that can aid clinical management. This started with my mentor, Professor Juliana Chan, with the Hong Diabetes Register, started over 30 years ago with a matched biobank. And then around 15 years ago, we started a multi-center biobank together with other colleagues and endocrinologists across Hong Kong. And we've been building on omics data to try to facilitate biomarker discovery. And I'll touch on some of that. Of course, the focus is to try to use this information to better understand the heterogeneity of diabetes. And there are different aspects that we need to think about. One, of course, is treatment response, how individuals may respond differently to treatment, as we heard from the plenary talk this morning, but also in terms of progression of diabetes towards need for insulin, as well as towards the development of complications. So this is just one example of using now territory-wide data from Hong Kong, around 380,000 individuals who are captured in our territory-wide database within the hospital authority, which is the major health provider in Hong Kong. And if we actually take new users of medication, including metformin, DPP-4, TZD, and of course, there are many ways you can look at glucose response. This is just the most crude one, which is the change in A1C 1 year after starting new treatment. You can appreciate that it's really a great spread in terms of the glucose response. To the left is A1C lowering, to the right is actually worsening over 1 year. And of course, you can see the biggest effect in terms of glucose lowering tends to occur with metformin and sulfonylurea, but you can appreciate the spread in terms of variability in terms of the response. The same goes with risk of complication, and this is looking at diabetic nephropathy, around 5,000 individuals free of CKD at baseline, looking at the eGFR decline over subsequent follow-up. And again, you can appreciate this spread in terms of the variation. And if you arbitrarily use 4% drop per year as a rapid decliner, there's a significant proportion of rapid decliners amongst our population. However, we don't assume a linear decline in renal function, and we use things like latent trajectory analysis to look at hidden patterns within renal function decline. Again, you can see actually around 83% have this rather gradual decline in renal function, but you have a small proportion of patients who have more rapid decline, which we call accelerated decline, in some intermediate forms. And of course, it will be useful to identify risk factors or markers associated with subgroups to try to intervene early for these high-risk individuals. But of course, diabetes is complex in terms of the diagnosis itself. This is a slide borrowed from Dr. Shivani Mishra from Imperial College, because what we label as type 2 diabetes is actually not one disease. We tend to think of type 2 diabetes as a disease, but in fact, as we've heard, there are many forms of diabetes, monogenic forms, atypical forms, type 1 diabetes that need to be excluded. And in fact, we don't have a good way to diagnose type 2 diabetes, which should be a diagnosis by exclusion. So it's the only form of diabetes where we don't have a definition, in fact, and very much relying on sort of omics markers to help us. So thinking about all these, many groups, including ours, have been trying to find ways that we can better dissect this heterogeneity in diabetes using a probably specific risk score or other methods to try to separate individuals into those with underlying autoimmune pathology or monogenic forms, or identify those at high risk of complication. And of course, this is sort of the concept behind precision medicine in diabetes, and several of us are involved. Many of the audience are involved in this international initiative and started by the ADA and ESD and led by Paul Franks and Steve Rich in trying to review the current literature in terms of what we can do and what is the evidence of precision medicine in different aspects in terms of diagnosis, treatment, and also in terms of predicting complication. And I think just to summarize some of the low-hanging fruits currently in terms of the prevention, diagnosis include trying to identify those at highest risk to try to identify them for lifestyle intervention, for diagnosis of diabetes using autoantibodies, C-peptide to identify those with type 1, testing for monogenic forms of diabetes, and applying these diabetes subtypes or pathway-specific risk score to better identify individuals who will respond to particular treatment. And of course, there are now many risk engines, both clinical factors and biomarkers to predict complications. So these are some of the sort of areas where they are closest to implementation, we would think. So in terms of thinking about the underlying pathophysiology, one aspect that is increasingly important is this issue of type 1 diabetes in adults, because in the latest IDF Atlas, we were tasked to review the literature on type 1 diabetes in adults. And we did a systematic review of adult onset type 1 diabetes in terms of incidence. We were very surprised to see that, yes, in Scandinavian country or European population, of course, you have much higher rates of type 1 diabetes in adults compared with Asian population. But regardless of the region, you see that if you go by the age groups, type 1 diabetes, of course, is highest in childhood and adolescence, but it doesn't go down with increasing age in adulthood. So actually, there's a significant proportion of late onset or adult onset type 1 diabetes that we're missing as they come into clinical practice because we don't routinely look for them. So this is an increasing issue. And this is further compounded by the fact that in Asia, we have this young onset diabetes. So this study 20 years ago done by my mentor, Professor Zhiyong, actually looked at this problem and is still very insightful now. So back in those days, 2001, Jelena looked at 145 young onset diabetes, all with family history, positive family history, 13% of which fulfill traditional criteria of MODY only. You can see that about 14% carry mutations in the classical MODY genes and 4% had autoantibodies, so they probably had autoimmune pathology. But for the great majority, there was no obvious cause, and they had a very high prevalence of albuminuria and renal complication, partly driven by the obesity. So one question is, could it be because in these young individuals we're missing MODY genes? That's actually not the answer, because more recently we've now looked at NGS panel in more MODY genes and we're not finding more of it. So if you look at traditional studies that actually use MODY panel to look for highly enriched individuals with strong family history with young onset diabetes, yes, you get a yield around 18%, which seems fairly high. But we've recently done 2 studies, which is unselective in young non-type 1 diabetes, age of onset less than 40 with negative antibody. And this is a retrospective analysis on diabetes register, mean age of onset 33, strong family history in about 60%. You can see only 2% in fact carry any pathogenic or likely pathogenic variant in any of these monogenic forms of diabetes or metabolic genes. And in the ongoing prospective clinical trial for 800 individuals, again, only 5% had variants in MODY genes, 5% were antibody positive, and 8% had low C-peptide. Again, childhood obesity seems to be the main driver, present in 50%. So what is the underlying pathophysiology in these young onset lean individuals as opposed to obese individuals? And this is an interesting study that our colleague Andrea did, where she matched individuals with young onset diabetes, both lean individuals and those who are overweight with healthy control, and looked at the beta cell function. And you can see the non-obese individual had BMI of only 21, whereas the overweight ones had a mean BMI of 33. And there's a preponderance of metabolic syndrome traits in the obese individuals with or without type 2 diabetes. So when she did a hyperglycemic clamp, trying to create hyperglycemia and look at beta cell function, you can see on the upper, the blue and the purple are the obese individuals with or without young onset diabetes. The purple with young onset diabetes is predominantly decreased in first phase insulin secretion, whereas for the normal weight individuals in red and those with young onset diabetes with normal weight in green, there's an impaired beta cell function, highlighting the beta cell dysfunction as the main driver, especially in this population. If you actually look at the relationship between insulin sensitivity and insulin secretion, then in fact, they lie on the same hyperbole. In the open circles and triangles are individuals without diabetes, and in solid circles and triangles, those with diabetes with or without obesity, they have dropped off this hyperbole as they progress towards diabetes. So this highlights the importance of the beta cell defect, and Miriam has very nicely talked about the pioneering work that they've done in looking at pathway-specific polygenic risk score. And thanks to that, we've been able to try to apply this as well as the heart clustering pathway-specific risk score from the GGI in our Chinese population with type 2 diabetes. And you can see using either method, you can nicely identify both the beta cell pathway-specific inherited polygenic risk, as well as obesity risk tracks with the clinical phenotype, where those with low beta cell specific polygenic risk score have a high BMI is inversely correlated, and those with high obesity related T2D genetic risk is associated with obesity. And we're also seeing the differential association with complications. But in terms of thinking about the normal weight individuals with type 2 diabetes, in fact, as expected, on the x-axis is the Z-score for polygenic risk score. Those with normal weight have significantly higher total T2D polygenic risk burden. But in fact, if you go into the specific pathway, as expected, they have a higher risk of carrying polygenic risk score for beta cell specific and also specifically lipodystrophy, as Miriam nicely showed that this is one of the reasons why the Chinese individuals develop type 2 diabetes at lower BMI. And the obese individuals the overweight individuals have a significantly higher contribution from the obesity-related type 2 variants. So thinking about treatment response, again, there are clinical factors that are strongly associated with treatment response. These are data from colleagues from Exeter, whereby non-obese males in general have lowering of A1C, greater response to sulfonylurea, whereas obese and overweight and females tend to have greater response to TZD. And they also identify, for example, insulin sensitivity as being strongly linked to response to DPP-4 inhibitor. So what about Asian population? So again, using population-based data, we've been able to look at clinical factors associated with response to glucose-lowering agent, and essentially we see almost the same. So sulfonylurea, the main factors associated are male individuals, older individuals, and shorter duration. For TZD, greater response to female, more adiposity, an SGLT2 inhibitor, obese, and short duration. So we're beginning to be able to perhaps use some of this clinical factor to derive sort of calculators or prediction algorithms that can predict glucose lowering effect. So finally, complications. So there's been lots of work in trying to identify clinical factors or biomarkers that can predict developmental complication. We have many risks like UK-PDS risk engine, as well as other models, RECODE and others that can predict cardiovascular complication in diabetes. So, but you don't necessarily need to go to complex biomarkers, because even using clinical factors such as in our young onset diabetes, comparing type 1, type 2, and overweight type 2, you can see, in fact, it is the overweight individuals with type 2 that has the highest progression towards renal complication. And this is similar to what was seen, of course, with the Elquist clusters, with the severe insulin-resistant diabetes having the fastest progression towards nephropathy. We've been trying to look at other biomarkers, and this is an example using methylation marker in individuals with type 2 diabetes. But instead of just looking for the strongest associated methylation marker, this analysis led by Kevin Yip and Kelly Lee, we tried to build a prediction model. And interestingly, most of the CBG sites most strongly associated were not included in the prediction model, indicating perhaps some interactive effect. But using a prediction model, just using 64 CBG sites, we could predict eGFR, and the predicted and the measured eGFR were strongly correlated. That alone had fairly good performance, AUC about 0.9 compared with clinical risk factors, and can have better prediction for end-stage renal failure. And interestingly, when we take the data set across to work with Kathleen Sustek and Rob Henson using data from the Premium Indian population, again, we could validate the prediction of renal function. So there's sort of cross-ethnic validation. And this is just one example of now trying to apply machine learning methods. This is using data in individuals over age of 65 and to predict severe hypoglycemia and hospitalization in the next 12 months using the clinical database. And the best, we explored sort of 6 models, and the XBoost model had the best performance and was significantly better than sort of a clinical risk model. And now is how to implement this in the clinical algorithm. I just want to finish with a few thoughts on how we can implement some of these biomarkers, because identifying biomarkers predictors is really only the beginning of this long journey towards precision medicine. Regulatory approval, patient engagement, and also demonstrating these in clinical trials are important. So some of this is been useful experience. My mentor, Professor Juliana Chan, having developed clinical risk algorithm in our population, decided to go ahead 15 years ago to actually think of how to implement this in clinical practice. So she built this electronic portal to incorporate these risk engines into a management portal that provides decision support, and showed in sort of longitudinal analyses that centers that have access to this seem to do better. But she went on to actually test this in randomized clinical trial together with colleagues across Asia. This is a study looking at individuals at high risk of diabetic kidney disease, and then they were randomized into 3 arms, just standard care plus access to this JADE portal, and then access to this JADE portal together with a nurse educator, which showed that that actually had further enhancement in terms of patient engagement and improvement in terms of the basic targets, A1C, blood pressure, and also use of ARBs. What about adding genetic factors onto sort of this sort of intervention? So recently we've tried to do a randomized clinical trial where we've added on genetic factors to this JADE portal in half patients at high risk of kidney disease and coronary heart disease, to see if they find out they are at high risk of diabetic complication, whether that would motivate them to improve their glucose control. So we looked at percentage of patients that achieve target control, as well as disease progression as secondary outcome. And essentially both the JADE portal as a sort of algorithm, as well as adding on genetic factors, improves sort of A1C achievement, but in terms of 3 out of 5 targets, then both were actually comparable. But interestingly, we found that giving the genetic information did empower individuals to do something about their diabetes in some of the patient-reported outcome. And as we predicted, patients at high and low genetic risk, in fact, responded differently to that information. So you need to think about how to tailor the messages. So we sort of think that perhaps one way to approach delivering precision medicine in diabetes, in particular for our young onset patients, is to do better phenotype at the beginning, perhaps including searching for monogenic forms of diabetes, and then incorporating polygenic risk score to guide treatment management, bearing in mind that, of course, organ protective therapies need to be selected earlier on, as the preferred decision, but in the absence of need for that, then guide by treatment response. But of course, we need to demonstrate utility of this sort of approach. So we're just finishing a randomized clinical trial where amongst individuals with young onset diabetes, we are providing and randomizing half of them to this approach of giving omics information, next-gen sequencing, polygenic risk score, with the other half just getting the clinical information, looking at clinical outcome and emissions. So the decisions are guided by the adiposity, as well as, of course, those in monogenic diabetes getting the appropriate treatment, and those with poor beta cell function preference to incretin-based therapy. So to summarize, there's a lot of hidden heterogeneity in diabetes, especially amongst the young onset diabetes, which is a major problem in our region. There are now increasing evidence of how we can stratify individuals based on the underlying characteristic, and hopefully there will be more examples where we can try to implement this to try to improve our care for people with diabetes. I just want to finish by thanking, this is a collective effort from our group led by Professor Juliana Chan. Andrea did many of the work on young onset diabetes. And also we want to thank our collaborators both within Hong Kong and outside of Hong Kong. And thank you for your kind attention. I'll be happy to take questions later. Thank you.
Thank you, Dr. Ma, for your thoughtful presentation. We are in now for another fantastic conclusion to our session with Dr. Wei-Qi Wei. He is going to present on revolutionizing phenotyping, how AI is shaping its future. Dr. Wei is an associate professor of biomedical informatics at Vanderbilt University Medical Center. He is a PI in Emerge Network and a member of the Coordinating Center for All of Us initiative. His interests include high throughput phenotyping and clinical pharmacogenomics. Thank you.
Thank you. So, great pleasure to be here. So my lab specializes in very large EHR analysis. So talking about the EHR data, most people think about observation studies, which is very true, but I just want to emphasize that EHR data actually, EHR-based research has already touched, all different levels of scientific evidence generation. So people working, I receive from time to time requests from people working on the wet lab bench work and require some information using real world data to validate their findings. And also, EHR data has been, research has been designed for some, smart clinical trials. And also you can see the meta-analysis paper, start working using more and more, cite more and more evidence from using, EHR-based research. So in order to do a EHR analysis, phenotyping is the basic step, which means you have to identify patients. If you want to study type 2 diabetes, you have to identify patients from EHR, what is type 2 diabetes. So phenotyping basically is the, by definition, is the developing, standardizing, implementing, and organizing a strategy that can help you identify those patients from the EHR. So when I start working into the space, when I start using EHR to do phenotyping, my initial thought is pretty straightforward. I said, give me the diagnosis, I'm gonna finish my job. And then I gradually realized that's pretty naive. And so there's too many reasons, simply using diagnosis won't able to help you. Chart fragmentation issue, patient went to different hospitals, you don't have a complete medical records. And inaccuracy is another example. The patient got a type 1 diabetes, type 2 diabetes, cold as well. You don't know which one is correct. And also, inaccuracy for data extraction. This morning we have lots of talk about, lots of information hidden in the clinical notes. You have to working through NLP, a larger model, to pull out those informations to analysis. And another very unique, tricky thing about the phenotyping actually is the terminologies. People familiar with the EHR knows EHR has different domains. A lab, they use line codes, medication using RxCOEs. And when we talk about clinical notes, people talk about SNOMED concepts. Of course, diagnosis, ICD. Even, Hong Kong, you use it, I guess, ICD international version, and we have international, we have ICD code modification version, which is, slightly different. And so there's tons of problems. So you have to combined with the different information within EHR together in order to get the reasonable good performance. Actually, the right one figure shows the type 2 diabetes algorithm, which is actually the very first EHR-based algorithm has ever been published in the world. So created by the Emerge network. You can see that actually it's a combined, different differential diagnosis, type 1 and gestation, diabetes codes and the different labs and different medications. You put them together, put some very complicated logic together in order to get a pretty good performance. So this is a very traditional phenotyping process. That's what we're doing. Still, we're doing this. Follow this process. So we start with the domain expert, like type 2 diabetes physicians working on draft algorithm. Then we need to find someone information to help the physician to turn that code into executable code, and then we run the algorithm. And then we evaluate the initial performance. If it's not good enough, they will probably go back to the physician or domain experts to modify the algorithm, then rerun the algorithm, reevaluate, and initially we think it's good enough, then we release the algorithm to the public audience. So there's many problems in this process. I just want to say, two things. Number one is that we start with the domain expert, draft algorithm, and sometimes they have no idea how to find those in EHR, and sometimes they don't even know what is the relevant CPT code for that one. So usually that take a lot of time to do that, to get the first draft. That's number one. And number two is, if you look at the process, it's kind of like a linear process. Once the algorithm has been finalized and shared with the public audience, then usually it marks as the end of the journey. Then it's after the study finished, then no people gonna reuse the algorithm. So that's the two major, I think it's a problem. So this is the lessons we learned from the Emerge network. For people who are not familiar with the Emerge network is the NIH-funded consortium, which has over 15 medical centers across the United States. So the primary focus of the Emerge network is trying to leverage electronic medical records information to promote genomic medicine. So we are, pretty familiar with the EHR. We do lots of phenotyping together. So this can show you, the X shows the, it's a 5 years from 2015 to 2019, 2020, and the Y show you how many unique algorithm we generated. You can see, it took 5 years, 15 medical centers, collaborations to generate eventually 25 algorithms. You think about this, it's pretty expensive to do that. And so two things I want to emphasize here. Number one is if you look at the performance, you can see that the domain expert generated algorithm pretty accurate. This is pretty valuable. And number two, is that the time, it took a lot of time and labor to generate those algorithms. If you think about even diabetes, there's a different outcomes, different type of diabetes, and you want to study different medications. If you want to, based on domain expert to generate algorithm for each particular phenotype you're interested, then that's probably not gonna work. And another thing is the knowledge we generated through the through the Emerge network as a general type 2 diabetes is pretty valuable because the performance is really good. And so how to what we are doing here is we're trying to leverage the power of AI to help us improve the process of phenotyping. So what we propose to do is instead of domain expert or physician general algorithm, we want the AI to help us to draft the first algorithm. Then instead of the physician develop the algorithm from the scratch, the physician just review the process and make some suggestions. So that's gonna save us a lot of time. Another thing is the AI got a lot of knowledge. The AI can learn lots of knowledge from the tools we created. People may heard a fee code the lab generated, and the fee code, the fee map, MADI, those knowledge together, all different type of knowledge together. And also the previous algorithm we generated from different studies. So we can feed that into the AI algorithm that's gonna help us eventually to build a better algorithm and to build up, identify the knowledge gap, help us identify some new knowledge and new hypothesis. So, or I'm gonna show you some pilot studies using the large language models. So the first one is about the drug repurposing. That's the ones, that's about, 1.5 years ago when just Microsoft released the algorithm, released the ChatGPT. So a student from my lab just approached me to say, I really want to do something about the ChatGPT. I was quite skeptical around that time and said, okay, and I forgot about what we discussed, but I just, disagreed with the idea. But then I said, after after the call, I said, why don't you just ask ChatGPT to give me some drug repurposing candidates for Alzheimer's disease. So I say that the reason is like, people are familiar with the Alzheimer's disease, there's not a lot of treatments available. So people are, very anxious to learn what drug repurposing candidates can be used, or proposed, but, not very successful. So we are pretty good at, analyzing EHR data. But for us, the problem is once we're using EHR to generate a hypothesis, we're losing our validation resource. So that's a big problem. So of course we can use the genetic, that's a separate story. But so in that particular case, I asked my student, go back, give me candidates, ask ChatGPT. And after 10 minutes, it called me back and said, can you take a look at your email? I sent you the list. I was quite shocked when I saw that list. It's a really nice candidate. I said, okay, then we got an idea. This is what we're gonna do. So we asked ChatGPT to generate the multiple drug repurposing candidates for us. Of course, we promote, ask ChatGPT multiple times, and we summarize the top candidates. Then we said, we're pretty good at doing, EHR analysis. We're gonna use a large EHR data to validate the hypothesis, see which one is true. And so we have available data, we have all of us data, which is, multi-medical center data. And so here the hypothesis, here's the results. You can see that ChatGPT mentioned like metformin, losartan, which is quite reasonable to me. And actually, we can validate the metformin and losartan using, very large EHR data. And actually, metformin and losartan right now, I think is under clinical trial 3. So we're probably gonna see the results in either 2025 or 2028. We're gonna see what the clinical trial looks like for Alzheimer's drug repurposing. So after that, we think it's interesting. So let's move on to general phenotyping. So I want to understand if large language model can really help us do some phenotyping work, because that's a very inefficient process at this stage. So we move on with that. So we test the different large language models like GPT-3, GPT 3.5, 4, Cloud 2, and the BARD. So we test different large language models using different phenotypes. We're looking for hypothyroidism, dementia, type 2 diabetes, and we ask ChatGPT to identify the important features and construct the algorithm and turn that into a SQL code for us. Then we also, compare the performance based on number one is a manual chart review based on domain experts' opinion, and also we run that performance against the image network algorithm, which is considered pretty good performance. So interesting, this is for type 2 diabetes. You can see, larger model really can help us identify the most important features for type 2 diabetes, diagnosis, different labs, and the medications. Of course, emerge algorithm, which is a pretty, domain expert general algorithm, may have some, different opinions about the exclusion code, as an exclusion code, et cetera, and sometimes the ChatGPT, old version make some small mistakes, understand some wrong error code, but it looks pretty nice to me out of performance. So this is what we learned, generally speaking, compared to different large language models, GPT really outperform others to identify, relevant features for a particular phenotype. And we try different prompt strategies, and it looks like very similar, which means out of the box, if you directly ask a ChatGPT to give you an answer, they can do pretty nice. So, in the last slide, I'm gonna re-emphasize, the importance of using the EHR data. This is the number of publications each year using EHR data as a resource. You can see the number is growing rapidly, and actually we are looking to see, expecting to see like a 10,000 unique papers every year using EHR data. And actually the number of publications doubled every 4 years. And also, you know, the EHR makes some very important, has been become the backbone of some very important networks, you know, consortium collaborations. Emerge network is one of them. All of Us is one of them. And also some important work like the M.P.H, which is recently funded by NIH, talking about maternal and pediatric research. So I know, you know, the diabetes are very complicated symptoms. It's not disease. So, and it's a touch lots of organs, you know, it's just tons of phenotypes we want to explore. And hopefully, you know, by leveraging the power of AI, we can, you know, help different, you know, researchers to identify their own phenotypes more efficiently and more precisely. So that's why it's my, you know, thank you to all my fundings and the collaborators from, you know, across the US. Thank you.
Dr. Ree. Now I would like to invite our esteemed panelists to take their seats. We're going to have about 25 minutes for our Q&A. Please, when you come down to the mic, make sure to introduce yourself and share with us your affiliation. And just to make this the most enriching and interactive, please, we encourage everyone to participate, especially trainees and early career investigators. Thank you.
Thank you for your talks, John Caduce from City of Hope. Miriam, your talk and yours, you both had a cluster that was lipodystrophic, I guess, individuals. So curious if you can talk to one another and if you would find that your cluster would identify that as the same thing. And then the second thing, maybe you already were talking about that, but the second thing too is if you take those clusters and you put them in a non-diabetic population, would any of them cluster as such? And the same thing too, if you took it for a type 1, which might be odd, but the point is how do they, you know, how do they cluster? Yeah, thank you.
I think I said we should. Okay, got it. Yeah, great questions. So I'm involved in Radiant. I'm one of the PIs, and our team at the Broad has looked, so we started looking at polygenic scores within the Radiant data set. So I think, you know, people that have monogenic disease often will have, you know, a rare variant driving the phenotype, and then may not have as much of a, you know, depending on the situation, may not have as much of a contribution for the polygenic risk. So I think what we're seeing so far in Radiant is that, you know, we're really at preliminary stages of doing these analyses, but that lipodystrophy group is probably more of like a monogenic lipodystrophy group rather than a polygenic lipodystrophy group. But there may be individuals in there that have kind of extreme of the polygenic risk, and we need to look into that closer. But so far, our initial analysis doesn't suggest that they're significantly enriched in the lipodystrophy alleles. But it's but I think that it's a very preliminary analysis, and also, you know, that we're, you know, these analyses are very much changing as there's more and more enrollment in Radiant, and we have kind of one of the challenges is that it's a relatively small group of individuals in that. So I think as we have more individuals part of that group, maybe we'd be able to have better power to do that analysis too. That's a great point. Anything you want to add?
No, that's excellent explanation. I just wanted to add about the control group. So Radiant is designed for the cases only, but we are trying to work with Miriam to look at the TrialNet data, which we have controls and also TEDdy data. So we can look at ExpandNet, but it's very specific for the young type 1 diabetes population. What do we have?
And I think across, and Dr. Ma may be able to speak to this as well, but in general, when we look at polygenic scores, these process-specific polygenic scores, we do see the same clinical features in people with and without diabetes. So the scores are more enriched in people with diabetes, but you can find people without diabetes that seem to have, you know, for example, with like the lipodystrophy cluster, they'd have higher triglycerides, lower HDL, even if they don't have diabetes.
May I ask a question real quick? Just thinking about diabetes heterogeneity, and these different subtypes, would EHRs be the way to validate them? Or is that very ambitious?
Well, a lot of our analyses are in EHR right now. So the Mass General Brigham Biobank and all of us. So we definitely try to use EHRs. I think EHRs are incredible. They, as we heard from the last talk, which was phenomenal, seeing, you know, that trajectory of EHRs as part of research, like no question. I think that it's like the backbone of research now is EHRs, but there's major limitations when it comes to diabetes phenotyping because of, you know, when you really want to think about a diabetes phenotype, you want glycemic measures, you want, you know, more specific medication information. You want really accurately to know when someone starts and stops the medication. And I think that's one of the biggest challenges of the EHR. I don't know if other people want to speak to that too. It's a great question.
Yeah, I agree. I think it's another important thing is the what kind of EHR data you got. Talking about the, you know, genetic heterogeneity. You know, for example, Dr. Ma probably knows that Asian people usually like a lean diabetes or BMI very different from, you know, European ancestry. If we don't have sufficient data, then probably we cannot do anything about that.
Yeah, I just want to echo that. And also this issue, especially with this adult onset type 1, often in EHR, they miscoded as type 2, so they could actually contribute to sort of difficulty finding the heterogeneity as opposed to dissecting the heterogeneity. So I think you need both approaches.
Maybe a good point to pivot off that too is just that antibodies, you know, are often not measured close to time of diagnosis, you know, I think that's it, or, you know, that may not be measured at all. So there's a lot of missing data as well. Please.
Okay, so related to that, oh, sorry, I should introduce myself first. I'm Melanie Shapiro from University of Florida. So I wanted to ask about process-specific polygenic scores for type 1 diabetes. I think that there are a lot of lower odds ratio hits that seem like they might be in pathways, like for type 1 interferon signaling, or things related to regulatory T cell function. But I could also see it being maybe hard to apply this to a disease where there are some loci that have really, really high odds ratios. So would this even be possible to do? And has anyone tried to do this yet?
We are working on it. So it's a project. So there's a trainee who has a K grant, Aaron Deutsch. Specifically, that's one of the aims of his K. And so he's working on that right now. I say that the non-HLA regions are definitely mapping better to mechanisms. And I think the HLA region is more tricky to be able to map well.
Ashley?
Hi, Ashley Xia from NIDDK. I have two questions. First question, regarding to EHR, how much family history are captured in those EHR? I wonder whether there's any research actually compare the prediction you get from the family history information and also those fancy genetic studies.
I think it depends on this is a EHR quality issue, right? So it's different from like a CVD hypertension. That's usually we can see that in patients' medical records. So type 2 diabetes, I guess it depends. Usually I can see that from time to time documented in SNOMED concepts. So we do have those kind of information, but I'm not sure about, you know, you're gonna ask that every time. Or it's just particularly because the patient got some high risk and then you ask. That's part I'm not sure. It's just an EHR quality issue.
Yeah, I think maybe there's you know, if we could improve that, that maybe can save us a lot of money instead of doing genetics. That's one question. The other question really direct to Dr. Ma. I think what you presented really you already take what you did from the clinical lab into the translation, which is implement in a clinical practice. I just wondering whether you could give us some suggestions to the US population, see what are the critical steps to really put what we learned here into clinical practice.
Thank you for the question. I should emphasize that implementation, a lot of it is still in research setting, meaning clinical trials to demonstrate the effect. I mean, certainly we are trying to get, for example, the algorithm predicting hypoglycemia. We're working with the healthcare provider to see if we can have that incorporated. But often I show that sort of path to implementation that, I mean, we are generating the evidence, but trying to implement, you need to work with policymakers, with funding agencies, with the general public to educate, especially in Hong Kong, literacy about genetic information or health literacy is in general quite low. So to try to implement and say we want to use your genetic information, and we also don't have laws to protect against discrimination with genetic testing. So again, all these issues are things that we're contending with and thinking about to try to see how really in terms of implementation on a broader scale, how we can achieve it. So I guess we're all learning as we go along.
We have a question from the other part of the room.
Yes, Emory University. So actually I have more questions about genetics. So when people talk about type 2 diabetes and the phenotypes of clusters, right, we're trying to put people into these clusters, try to understand their clinical characteristic, like diabetes complications. For genetics, certainly there are good examples, like the multi-genes, rare variants. They can identify individuals into this unique group, but it's a very small percentage, if I understand correctly, right? For most of the type 2 diabetes, so what's the performance of using these like a partition polygenic scores or any kind of genetic information to actually improve the performance of the type 2 diabetes clustering?
Great question. So monogenic diabetes represents about 1 in 250 cases of people with diabetes. So it's not super, super rare, but absolutely it's, it's a small proportion of all diabetes. And so when we're talking about subclassifying within type 2 diabetes, we're assuming that we've kind of removed the people with monogenic diabetes. And I think, the dream is to be able to have ways to have genetic stratification. Right now, I would say that the process-specific polygenic scores more speak to mechanisms rather than the ability to have a clinical way of subtyping people. So most people are going to have a combination of multiple of these different processes contributing to the diabetes. There'll be some people that kind of have maybe their diabetes driven mostly by one mechanism, and those people, potentially could be especially interesting. Maybe there's some early studies that have been presented at some meetings suggesting that there's some people that have what's called MODY-X. So they look a lot like MODY, but they test negative. And in fact, some of those people have a very high process-specific score related to beta cell function, which you may expect. So there will be some people with type 2 diabetes where there maybe the common genetics can help stratify, but most people, it's going to be a combination of multiple processes. And I think that to me, the real translation there, the opportunity is not so much right now about subtyping people with type 2 diabetes, but rather understanding the mechanisms to improve management. And some of the drugs will likely be drugs that be useful for, many individuals.
Yeah, but clearly, like all these phenotypes, they're not like genetics, they're not the same across the lifespan, right? We have to incorporate the environmental information, other omics, right? Other physiological information. So, but this is a good like a foundation, right? We can add on top of that, I think that potentially, but that lead to my second very quick question to Dr. Wei, like for all of us, right? Everybody has genetics data. Is there a pipeline like you centrally can build the PRS calculation for everybody in addition to every investigator calculate by ourselves wasting the precious computational resources?
I think that's capable. Right? Of course, all of us got something. The platform ready for us to do that.
So, is there any plan to do it centrally, make it available to all investigators on top of the genetic data?
So I guess the tricky thing right now is about the ancestry. All of us is work across different ancestry, but right now the performance talking about the PRS is a majority of it's based on the European ancestry. And when you go to the different ancestry, the performance may not good. So which one to use? That's debatable. They do have a special group working on those kind of a project. But go back to your question regarding the genetic contribution, plus environmental factors. That's the major goal of the eMERGE 4. So Emerge 4 is working on that. We proactively recruit like, 25,000 individuals across the US and measure their genetic, calculate their polygenic risk score, plus family history, plus their certain, lab information together. But we don't have the result yet. We're gonna follow up for next 5 years. Probably we're gonna see how genetic make the contribution across different common disease.
Yep, thank you.
Great discussions. We have Paulina asking questions from participants on Zoom, correct?
Correct. So there is a question from Salvadori Sashi to Dr. Ma on the clinical trial comparing polygenic risk score and traditional clinical phenotyping. Can you clarify if there is a specific polygenic risk that would be actionable in a different way than what you would do based on the clinical phenotype alone? For example, presence of antibodies, glycemia, C-peptide, specific monogenic diabetes.
Thank you. Very good question. So I should clarify, the first trial that I talked about was polygenic risk score for risk of diabetes complication. And the rationale for doing that study, we were motivated by studies done at M.P.H, where people who tested high genetic risk for type 2 diabetes said they were more motivated to change their lifestyle. So we wanted to test the hypothesis that if someone was at high risk of diabetic complication, would they be more motivated to actually modify the risk factor as opposed to just telling them you have high blood pressure, you have high lipids, you're at high risk of cardiovascular complications. So that's the motivation that we tested that. Yes, you can argue you can use clinical risk factor, just tell them you are at a high risk score, UKPDS risk score for cardiovascular complication, do something about it. But our motivation was testing the genetic aspect. And that's also where we then found differences in terms of people who had high versus low genetic risk in the intervention arm. They actually responded differently in terms of how much they were empowered. So yes, you can use clinical information, but we were interested to test whether genetic information had that additional effect that people said they may respond differently. And for the young onset study, then it was a polygenic risk score for various things, for treatment response, for risk of complication. So we're really testing the whole strategy of using sort of next-gen sequencing to identify monogenic diabetes, polygenic risk score to look at overall risk, and then C-peptide and anti-GAG. So kind of look at the whole package of these sort of tools, whether it would make a difference in the difficult setting of young onset diabetes.
How much do you think, this is a question for everybody, I guess, and it relates, I think, some of the earlier questions, but how much do you think molecular characterization is going to clean up this whole business, meaning, and especially at the single cell level, because I think it is quite heterogeneous. I think we're looking at things at a pretty high level so that you wind up lumping a lot together. And I mean, let's face it, at the end, the polygenic risk scores aren't that good unless you're at the extreme end of the distribution. So love to hear your thoughts from the panel about how can we clean up this whole space?
I mean, I think some of the cellular profiling work that I mentioned is really exciting that, as you mentioned, when you get to the human, like whole body level, there's so many, and, we're talking about environmental factors, there's so much that kind of complicates how when you look at a phenotype, but the closer you are to the cell, the fact that there we can see these process-specific polygenic spores having like a very clear cellular phenotype. And so I think that's really reassuring that, so that one way to kind of clean things up is just to go closer to the source and to help us understand. And then ultimately, that's once you have that, that's also what that means is that, the translation of that can be if there's a treatment that you're interested in, you can actually look at that as a readout for a response to a treatment. So I think and potentially it could also be helpful in terms of progression toward disease to have these different, we're not going to be able to take biopsies from people, but to know, like to have readouts that are, kind of less noisy, I guess, the fact that they're kind of clean readouts. I think that's one aspect.
Well, certainly at the treatment level, probably don't want to belabor this. Obviously, one treatment can affect many subconditions. So that's an interesting one. Ideally, we'd like to actually use the subconditions to design new treatments to be more precise, getting the title, precision medicine. But maybe even, here's a way to put this to your question. You went from 5 to 12, I think, in one of your, did you learn more information when you went to 12 versus 5?
we're still learning. So I think, that's actually one of the most exciting aspects is that because this is data driven. So, on one hand, when you get something that you recognize, you see a group of loci related to beta cell function, it's like, okay, like that's what we expected. It's pretty clear. But then we're seeing these other clusters that like, I didn't get to go into it just because of time. Like there's one that's related to cholesterol levels that where the alleles that increase diabetes risk reduce LDL cholesterol levels and reduce risk of coronary artery disease. And one of the top loci is HMG co-reductase. And so we're actually capturing the pathway that we all very well know, the statin pathway that we know now statins increase risk of diabetes, but the whole mechanism there is not well understood. So I think there's this exciting aspect of where, there's so much more work to be done, but where this is kind of like an anchor that we can use these sets of loci to help direct research. We can, because often we'll be able to know the tissue, we can, do follow-up analyses that are going to be able to hopefully elucidate these mechanisms. I mean, it's not easy, but I think it at least gives us a path towards that.
I just want to quickly mention, maybe you can give AI a try, large language model probably can help us, identify the gap and probably link the dot. That would be great. That's just a hypothesis. I'm just saying, worth a try.
I'd like to try to give a slightly different perspective. We're interested to do omics to dissect biology because we want to understand disease. But I want to take one step back. Actually, just using clinical information, we already can do a lot. So in the systematic review of biomarkers for predicting complication that we did for the ADA EASD Precision Medicine Initiative, we found tons of risk prediction algorithms that can predict risk of cardiovascular disease in diabetes. But there were very few examples of them being implemented. Most had AUC about 0.8, so they're reasonable, they can be used in clinical practice, but there was very few implementation. Very few people using this UKPDS or better risk models now in clinical practice. And in terms of sort of treatment response, colleagues at Exeter, John Dennis and others have done beautiful work at looking at just clinical factors that predict drug response. So you can use genetic markers, you can use other things, but even clinical factors, things like age, BMI, duration of diabetes, things like that, renal function already can predict clinically relevant differences in A1C response of 0.3, 0.4%. So I would argue that we already have pretty good clinical information that we need to learn to better implement in clinical practice and then build on that with our sort of better biomarker-based algorithms as they come along. But I think sort of even with clinical factors, we can already implement some of that in clinical practice.
Hi, my name is Jake Chen from University of Alabama at Birmingham. I have a question regarding scaling AI using electronic medical record data. I think all of you have made great points, and we can do AI algorithm testing on small institutional or maybe cohorts that's regional. But then in the morning that we heard the talk that Cosmo dataset have 100 million covering half of the US population is controlled by the industry. And I'm scared that if Microsoft and Cosmo pair up together, there's the end of the business for us. Whereas we are innovative, but then we're so siloed, and then we cannot compete on the last leg, which is scaling it to the real world, make it equity and so on. Can you actually make some comments, or maybe with NIH, and do we need to work together or what?
Yeah, I guess my comment is like, for foundation model, you cannot compete with industry. Sorry about that. So, but, I guess, once the foundation model has been provided by whatever Microsoft or Google, then you can just easily build up your things upon that. Rare disease is a great example, right? So if you go to the, foundation model right now, ask a ChatGPT, give the real clinical notes, and identify the rare disease, the performance is super bad. But if you build up the model and give us additional layers, you can get the performance, improve, so pretty good. I guess, you probably, each institute may have your own interests. Like we are talking about the precision medicine for diabetes. So, you have, from clinical clinician points of view, you have your particular interest to that. That's cannot be replaced by anything. Right, so you just leverage the power of large data plus big AI to help you resolve the problem.
Did you get your question answered?
I was hoping for more bold answers. Maybe
Well, I think, I mean,
All right.
to me, one aspect of this is as a community, that we try to access more of those large data sets, through collaborations. It also brings to mind pharmaceutical, companies also silo data that we don't have access to. So I think there are a lot of examples where there's data that could be really useful that maybe as a community, we need to figure out how to get together to try to, I don't know how, but try to, put ourselves in the room to be able to get access more to those data sets that can make a difference.
So what I'm hearing, team science, collaboration, interdisciplinary participation. Am I right? Okay. Right, please, next question.
Hi, my name is Tejas. I'm a staff scientist at the NIH Clinical Center. I'm in radiology, so I come from an imaging bias. So I guess this question is for all of you on the panel. What I've seen so far is pretty much clinical information, molecular information, phenotyping, genotyping, things like that. What role does imaging play here? Because imaging is a huge component of a patient's journey through the healthcare system. And we are talking about, population health here, right? So diabetes is something that affects 90% of the population. So we see instances where patients have higher visceral fat, higher subcutaneous fat in the body, hepatic steatosis, like, liver disease, chronic liver disease that leads to HCC, and pancreatic diseases like diabetes that also leads to pancreatic cancers and tumors in them, like PNETs and PDACs. So we have tools in the clinical center that we have implemented in the PAC systems, which can actually segment and identify these structures. So I'm wondering, isn't it easy in the opportunistic screening sense, that is an incidental finding case, like for example, the patient has had imaging done before, could we not use these measurements to try to correlate against the diabetic status of the patient or any previously known measurements? What are your thoughts and suggestions?
Maybe I'll start. I guess I haven't talked about it because we didn't have the access, but I completely agree. I mean, imaging data is so important. And I think one important area is retinal imaging. There hasn't been really in discussion, but that started with diabetic retinopathy screening, but really has taken off. There's so many now AI programs based on retinal screening that can pick up a variety of disease from autism to various other diseases based on learning from AI. But certainly for MRI imaging, especially given that things like MAFLD and fatty liver disease sort of likely precedes diabetes, and there's a lot of whole body MRI imaging studies being done, or people trying to retrospectively review that to link that with clinical data. So I completely agree with you. Imaging data is key.
Okay, we have time for a couple of questions. Quick questions. This gentleman here.
Thank you, Pinaki Sarder from University of Florida. Thanks for the very exciting discussion, and going back to what the previous person said and Dr. Mike Snyder said, right? So yes, imaging is great. There are so my question is kidney precision medicine project, for example, where it's not diabetes, but diabetic nephropathy or diabetic kidney disease, those huge amount of histology and molecular data available. So how do you see, like, leveraging those kind of data, right? And bringing this, whatever the Atlas already has, how we can leverage that and combine some of the EHR data that the community has. Definitely the community data has a huge heterogeneity, but these are, when Atlas data is generated by KPMP, they are well QC'd. So how the community and this highly QC'd data can take advantage of each other and move things forward.
I'll try to give that a shot. So we've also been trying to do some of that, sort of trying to link renal biopsy findings of classical diabetic nephropathy with sort of phenotype. And I think sort of PPMI is doing a lot of that with sort of renal biopsies, linking that. But of course, in reality, we don't want to do renal biopsies if we don't have to, because it's not without risk. And I think the key would be linking those well-defined kidney pathology in people with diabetes, because right now we think diabetic kidney disease is very heterogeneous with a variety of different causes. If they can link that with the clinical factors as well as perhaps urine or other biomarkers, so we could have a non-invasive way of knowing this is classical diabetic nephropathy, I think that would be invaluable. And I think that's what sort of the field is trying to do. So to save needing to do renal biopsies, but yet having that clear dissection of what is the underlying cause of the kidney disease in this person living with diabetes.
Thank you.
Hi, I'm going to state the obvious again. The polygenic risk scores might be linked to diet or lifestyle factors, so that if we can identify the polygenic risk score subtype with patterns of lifestyle, then you could do the test early in life to motivate the individuals to adopt a healthy lifestyle. That's why you want to do the genetic test, not because it's going to add more information at the clinic for right now, maybe later. But we want to try to encourage people to live healthy. And we think that giving scores with the genetics and saying you're more predisposed, that might be a good motivator.
Yes, but I just want to devil's advocate. Yes, but what about if you are able to look at things like epigenetic changes, which can change with your exercise, which then motivates that individual, because with the polygenic risk score for predisposition to exercise having benefit, that won't change. So if you are able to work with a dynamic score which changes as that person improves, would that motivate that person more?
Sure. I mean, but let's start with the most important variables, and then you can fine tune them during life. Obvious, but we're not even getting to the top part yet, right? So I always think this is a Google map. Google mapping. We want to go down to the individual level, but right now, if we can get to the 10,000-foot level to know where we are with genetics and lifestyle, we're doing much better than we did before.
I completely agree. I think it's helpful to think about the data sets that we need to get to that. And so, I think one of our best resources right now for that is UK Biobank, because there's a lot of data on dietary choices. But really what we need is longitudinal data, because you want to know before looking at people before they get diabetes, what their dietary patterns are, and then who develops diabetes. And there's some of that in UK Biobank, but it's there's not a lot of longitudinal follow-ups. I think as a community, that's an area where it would be really helpful to get to that question.
Thank you, Cecilia Lee from University of Washington. So I'm sorry.
Can you speak up a little bit?
Cecilia Lee from University of Washington. So I know several of us kind of spoke about the power of the imaging being part of the EHR database. That would make it more powerful, since if you have raw imaging, you can always go and then recheck and then reevaluate instead of relying on the physician, perhaps bias, evaluation, or, that can create a lot of bias. But a lot of imaging, I know you mentioned retina imaging, so I'm glad. But a lot of imaging, including some of the retinal imaging, can be really big. Like, one person's eye visit could accumulate, more than 1 gigabyte of just imaging data alone. So then how do you envision, let's say like all of us, start getting retinal imaging or, multimodal imaging? Who's going to pay for the work that is being done in the Intracellular Research Network, or like what are your, potential options?
I don't think all of us collect image data at this stage. So
that was just an example.
I know.
Yes.
I'm just saying, so I don't have quite experience in using image, but I agree image data. But I do agree image data, especially AI power. Clearly the evidence is showing that AI can really work on some image. So combine multi-omic data, with for whatever disease, that should be very interesting.
I mean, I can imagine that's I think it's such a great question, and more and more, I think imaging data will be utilized. And so it might be, maybe there's an AI way that you can take all those images and condense to a smaller information piece that can be, continue to be carried on. But I mean, I don't know anything about that, but I think that's a great question for this community today, tomorrow.
Yeah, another thing I want to mention is, when we talk about the image, the first step is maybe you can consider like a radiology report, because when I work with the, different, domain experts, they're typically all the information they want is not from the image, but from the image report. If we can, leverage a large language model, work on the image report, radiology report, if the problem can resolve, then you don't have to, spend tremendous time, GPU, computational resource working on the image, the raw data alone. Just talk.
Did that answer your question? Yes? Okay. Next question, Anna.
Thank you. Thank you all speakers. That was a fantastic session. Anna Gloin, Stanford. I have somewhat two related questions. So thinking about the motivation to change behaviors, thinking about accessibility of data, what do you think the role is of our commercial partners here? So for genetic risk scores and modifying behavior, 23andMe would be a great example of an existing data source where you could look at longitudinal effects of learning your genetic risk and partition risk and seeing how it played out. So how do we engage better with them? And the second somewhat related question, which I'll put out at the same time so that you can pick which one you would like to comment on, is as somebody relatively new still to the US, having come from the UK and the national health system, where we don't really do electronic health records, I've observed in the US how fragmented they are and also how in some instances they're not really fit for purpose. So the way we cluster people into somewhat arbitrary groups based on their self-reported race and ancestry. So how do we again implement systems that are more fit for purpose so that as moving forward we can be collecting these data, which you're all showing are so important for integrating genetics and phenotyping in healthcare?
So yeah, so I guess I can think about the two things. Number one is volunteer, like all of us. The purpose is trying to collect all different people together, different ancestries, and especially under study the population, right? Another thing is is how can we get more information into the research? I would say for example at Vanderbilt, right? If I were you, I'll probably just talk more to my PCP and get more and more information through the EHR system. Once the data got into the EHR system and linked to the biobank, then we can study. Did I answer your question? I guess that's.
Sort of.
So I think I was thinking about your second question throughout the morning session. So electronic health medical record systems, vary. In the US, the ones that have really taken off are the reason they've been successful, I think everyone would acknowledge, is because they maximize billing and profit. And so it's really not about maximizing, clinical detail or, a benefit, I don't think, to the patients. So I don't know how we change incentives there or get it, speak to the people that are developing those electronic record systems, but that is a huge, if we could, there's so much inaccuracy in the way, in even like the diagnoses codes. I mean, sometimes there's just not a diagnosis code that's appropriate for what we want to put in. And so, yeah, if there are ways that we could improve that, I think it would make a huge difference to research, because so much research, it's kind of, junk in, junk out. And if we really want to move the needle there, I think we have to, but I mean, that's a massive task, but I think we have to have people involved in electronic health medical records actually understand the research and understand why it matters that there's more accuracy in the data being collected.
I don't know what is useful, but so in Hong Kong, all the hospitals are under one system. So we share one electronic health record. But even with that, we found data difficult to analyze because just clinicians diagnose disease using different ways. But one thing that we found very helpful is because we started doing this structured diabetes complication screening for people with diabetes, and we take them out of the clinic setting and do this structured assessment. And we've been doing it since 1995. And that subsequently got adopted by other hospitals across Hong Kong. So they also introduced that. So there is this one thing that we could rely on that is more or less standardized across. So if the field could for certain disease, say these are the sort of essential metrics that we would like as a field, and have that been able to be incorporated into service, then that would be one way of standardizing certain data that is useful and relevant. And then that could potentially, regardless of what sort of electronic health record, perhaps have some standardization of data that can be collected and then perhaps used. But I know that sort of with different healthcare systems, it's
Thank you.
No, I just wanted to add what he's saying, is to create some type of minimum standards for EHR data that can be normalized in a way that when person is analyzing or standardizing, it's much easier to integrate. But just adding to the point.
Thank you. Thank you all.
Are there more questions online, Paulina?
Right, we have a question from participant Eva Fain, who is a registered nurse, and she was wondering if it would make sense to look at insulin glucose response test coupled with renal clearance of insulin. So I guess her question is about how to couple two tests if they have more information than one test alone.
Well, I guess what I'm trying to figure out is how can I get someone to do that? But what happens now is when someone's sick, then we're like, oh, they're sick. We're not screening people before they get sick.
Anybody has answer to that on the panel?
I mean, I think there's, major of diabetes, and we don't do a very good job. We still don't really know well how to recognize like pre-diabetes, what's real risk versus people that won't progress. So I think what you're bringing up is a challenge. It's just that I think it's a cost issue of what you're going to clinical tests you're going in people's time that you're going to ask people to do. So yeah, I think we need better ways. Potentially this is where genetics can be helpful, or machine learning ways to identify people at higher risk that we should then maybe prioritize for different screening approaches. But it's just not feasible right now to do anything like what you're describing. Those types of tests I think would not be feasible across the general population, but maybe we could figure out as ways to identify the people that would benefit the most.
Right.
Yeah, and
Alfred, this is the last question of the session because we have to rush to set up the posters. We have like 10 minutes to do that. This was a wonderful discussion, great session. One big round of applause to all the speakers.